Ayan, good evening everyone. Good evening, Doc Broly.
Good evening,
Can
Ian.
you guys hear me? Okay, sorry. I thought okay yung laptop ko. Okay, I think we're already live.
Mag-play ka nga muna ng Christmas songs natin, pang-good vibes.
Sige, Doc. Sorry, Doc. Akala ko kasi okay lang yung laptop ko, but it's still, it's still not working.
Presenters view pa. Presenters
Ayan.
view, nakikita ko.
Nakikita niyo na po?
Presenters view pa rin yung nakikita. Naka-presenters view ang view namin.
Sorry, Doc.
Yes. Okay?
Okay na, Doc?
Yes.
Okay, sige. Doc, I'm sorry. Yung laptop ko naglono ko kasi nahulog siya. I thought it's already working. I tested it earlier. Kaya I'm not sure if I can play a video for this evening. Pero I guess we can start na lang siguro, Doc. It's already 7 o'clock.
Okay.
Okay, so good evening, doctors. To those who are inside my Zoom meeting and for those who are in the portal. So welcome to your Microbiology and Parasitology Summary Lecture and Quizmaster session. So before we start our session for this evening, let's all start with a prayer. So let's all remember that we're in the most holy presence of Lord. Lord, we thank you once again for this opportunity that you have given us. Thank you for this time. Thank you for the provision, for the health. Continue to bless us with motivation that we need towards the next few days for the last for the second half of our program. Please be with us. Please keep us safe and healthy, even our loved ones, Lord. We thank you for everything. In Jesus' name we pray. Amen. So again, doctors, welcome to your Microbiology and Parasitology Summary Lecture and Quizmaster. But before that, Doc Broly.
Okay, sino yung natin ngayon? Summary lecture teacher natin.
Okay, so for our... Hold on. Sige, i-introduce ko ba muna, Doc? So our... sa TV kasi ako. Sorry guys. Okay. So for our summary lecture this evening,
Naka-presenters view ko ulit.
yeah. For our summary lecture this evening, we have Dr. John Bendrick Borbe, a graduate of UST, Top 1, March 2019 PLE, a diplomate in Internal Medicine 2023, a graduate of IM Residency, Philippine General Hospital, and currently a fellow in training in gastroenterology, also in PGH. Do we start with Dr. Borbe first, Doc?
Hindi, sige, mag-ana. Kasi John already here.
Yes, Doc, I'm here.
Okay, alalayan, samahan mo ako dyan pag in-explain ko yung mga nasa clarifications.
Sige
po. Yung parts doon, hindi ko gets. Okay? Mas kabisado mo yan. Okay, sandali lang pa-enable ng co-hosting Ian para ma-share ko yung slides ko.
Sorry, Doc.
Share screen. Okay, for the corrections, clarifications, for microbiology and parasitology. First, regarding the handout corrections, we have no corrections for the top-notch micro and para main handout. Okay, yung second version, nilabas nila Prince and nila Jan, it's basically perfect in terms of any correction doon sa part na yon. So let's now go to the clarification. So tama yung nandun nakasulat sa handout, pero either may question yung paki-turn off Ian yung sound that when students enter the school.
Sorry, Doc. Okay po.
Okay. So clarification. So the clarifications portion, these are parts, questions given to us for the past 3 days via PM ng mga students sa akin. Okay. Asking about concepts na nandoon sa handout, okay, or mga differences between the references or differences between the handout and the video. Tama yung kasulat sa handout, okay, pero may tanong sila. So let's answer some of them. Okay, First is yung sterols or no sterols by Mycoplasma. Okay? So there was a mistake doon sa video na text overlay na kami doon. Tama yung nakasulat sa handout. So please follow the one in the handout. Okay? Mycoplasma have sterols but have no cell wall. The rest of bacteria do not have sterols but they have a cell wall. Okay, next. Page 3. Okay? Comparison table in the handout and lecture absent. Picture in the handout and lecture present. Final answer, none. Okay? So, Jan, can you explain this one, yung periplasmic space? Kung bakit iba yung nandun sa picture versus yung sinulat na text sa handout?
Okay. So for this question, no, actually later I'll also show you a figure. So yung periplasmic space kasi, no, it's present in both the gram-positive and the gram-negative organisms. But for the gram-positive organisms, super liit lang niya. Di ba? Kaya doon sa picture, pansin nyo parang almost negligible yung space doon, di ba? So it's not really a key feature, hindi siya defining feature ng mga gram-positive organisms. And that's the reason why most references would just say na wala silang periplasmic space. No? So actually even sa Jowets, yung sa table natin, yun naman yung pinakasusundin talaga natin, di ba? Whatever is in Jowets, sinasabi na lang na simply pag gram-positive, there is no periplasmic space. Okay, so for exam purposes, mas safe din kung yun yung sasagot natin.
Okay, thank you so much, Jan. Okay. Next, bakit Mycobacterium tuberculosis yung sagot sa page 8 na question? 39-year-old male consults because of chronic cough of 1 month. Sputum culture reveals colonies first observed after 2 weeks of incubation. So critically 2 weeks. The colonies appear rough, dry, buff color. That's the most likely organism. So it's Mycobacterium tuberculosis. So Prince Rubio gave answers here. Okay. This is Mycobacterium tuberculosis, tama, because of the clinical features na chronic cough for 2 weeks. Lab features, take note that Mycoplasma H. influenzae will grow within 2 to 5 days. But your Mycobacterium tuberculosis is a slow grower and it will take weeks before culture tests positive for tuberculosis. So 2 weeks. So with these factors alone, chronic cough plus the long period of time, okay, we can already answer the case with the best option, which is Mycobacterium tuberculosis. Anything you want to add here, Jan, sa part na to?
Well, yun naman yung appearance ng culture of your Mycobacterium tuberculosis. Very classic yung rough, dry, and buff-colored colonies. So seldom would you hear these descriptions for other organisms. So pag narinig natin yung most likely, it's Mycobacterium tuberculosis.
Okay. Page 16, okay, ang tetanus prophylaxis. Iba-iba yung doc yung nakasulat sa micro, sa IM, sa surgery. Actually, nag-uusap-usap na yung mga teachers regarding this one. It has something to do with the sources being utilized. Okay? So the one utilized in your handout, okay, is the CDC version ng tetanus prophylaxis. Take note, iba to dito sa PSMID, Philippine Society for, ano yung PSMID dyan? Infectious disease ba to?
Yes.
Okay.
Microbiology and infectious diseases.
Microbacteria. Ano yung
So,
style natin dito? Ano yung susundan nila for the exam? Itong nakasulat sa handout nila, the CDC?
So actually kung sa akin, no, yung CDC yung mas safer sundin kasi yun yung mas widely na ina-apply. Even when I was doing duty sa San Lazaro na talagang dun yung IDS natin na center, di ba? So mas sinusunod yung sa CDC. So most likely, I think kung may mga examiners tayo gagawa ng question, they would be more familiar with this, no, yung sa 5 years na duration.
Okay, so this was brought up. We're going to inform actually our teachers in IM and surgery to also follow this one for tetanus prophylaxis, itong sa CDC. So hindi natin susundan, mag-veer away tayo from PSMID. Susundan natin for exam purposes, universal sa buong top-notch, itong CDC recommendation for tetanus prophylaxis. Okay, next question, Vibrio vulnificus versus Vibrio parahemolyticus. Is the former vulnificus more common in raw shellfish? So from Dr. Rubio, Vibrio parahemolyticus is mostly associated with gastroenteritis after ingestion to shellfish. Vulnificus is associated with acute necrotizing fasciitis after traumatized skin is exposed to seawater or traumatized skin exposed to shellfish or fish. Okay? Miliary versus disseminated tuberculosis. So, Doc, parehas lang ba? Synonymous ba ang terms na miliary and disseminated? Kasi sa micro, parehas, pero sinabi ni Dr. Kevin Elomina and emphasized it's different. So, final answer from your teachers. May konting technicalities dito. Miliary tuberculosis is considered a subset of disseminated TB. So, it's not exactly the same. It's not exact technically synonymous. Okay? But because it's a subset, may may konting similarity talaga sila. So miliary TB is a severe form of disseminated TB. Miliary TB is a severe disseminated form of TB where the bacteria spreads throughout the body, causing tiny millet-sized granulomas in multiple organs. Disseminated TB, meanwhile, typically involves specific organ involvement, while miliary TB is characterized by widespread dissemination throughout multiple organs and can be life-threatening. Okay? Next, ito papa-explain ko din kay Jan to. Centrifugal or centripetal ba ang varicella spread? Jan, pa-explain nga nito. At very, palagi mga estudyante natin regarding
Yes. So actually, even during our batch, ito din yung common question sa amin nung nagbo-board exam kami. Kasi paiba-iba yan, whether micro or patho, kung centrifugal or centripetal. So finally, naintindihan ko na rin kung bakit ba siya iba-iba per sources. No, kasi the references, yung textbooks natin, they would use the terms differently. So when they say na the rash spreads centrifugally, centripetally, it means to say yung pattern ng pag-spread niya kung saan siya pupunta. Is it from the trunk to the extremities or extremities to the trunk? Ganon. Pero pag sinabi naman natin na yung distribution is centrifugal, no, or is it centripetal, ang point naman natin dito is where is it mostly found? Is it mostly found in the trunk or is it mostly found in the extremities? Nagagets ba yun? So, magkaiba yung point na yun. Kasi I can say na centrifugal siya in the sense that it spreads, say for example, to the trunk, to the extremities. Pero, at the end of the day, yung distribution is still majority nasa trunk. So, centripetal pa din yung distribution. It's just that the manner of spread nung rash natin is centrifugal. So ganito yung point natin for varicella. So it spreads in a centrifugal manner, no? So from the trunk, no, going to the extremities, but the distribution is centripetal. It's majority of the rash would be found in dito sa gitna, no, sa trunk and even in the head, sa face. Okay.
So centrifugal spread, pero centripetal distribution.
Opo. So ganun siya.
Pakisulat niyo guys, centrifugal spread but centripetal distribution ang varicella. Okay? Next, correct treatment. Okay, video lecturettes, cleaned up plus cleaning, okay, but handout atovacone plus azithromycin. So, iba yung nakasulat binigay ni Tiff Uy dun sa lecturette na QR code ninyo, iba yung nakasulat sa handout. Follow the handout, okay? That is more updated. Double check na yan ni Doc Fritz. Okay, next. Okay, iba-ibang references, iba-iba yung nakasulat. The gold standard in the diagnosis of Trichomonas vaginalis. In your handout, it's direct microscopy. Okay? In the Belisario, it's textbook, it's culture. In the flashcards, it's NAET. So final answer natin will be NAET and wet mounting. This has something to do with different sources referring to all of these three as gold standard. So iba-iba depending on your reference na tinitingnan. So Dr. Rubio gave the following. Currently, wet mount NAET testing are regarded as recommended test for detecting trichomoniasis. Clinical presentation, if observed, coupled with laboratory findings, would lead to the correct diagnosis of trichomoniasis. For the time being, consider wet mounting as the gold standard since it directly observes the organism and it meets the definition of the gold standard. Diagnostic test that is the best available under reasonable conditions. The tests against which new tests are compared to gauge their validity, and it is used to evaluate the efficacy of treatment. All of these three are correct. Direct microscopy, culture, and NAAT. They have their own references. Okay, dahil nagbabago yan across the references na ginagamit. But for top-notch purposes, for the board exam purposes, universal across the top-notch system, please use NAAT or wet mount, okay, pag tinanong sa exam. Okay? Take note, iba-iba yung nakasulat sa reference, depending on your references. but we will utilize this. Okay? Para sa lahat. So that's it for the corrections. No corrections for micro. So nakakadalawang subject na tayo na no corrections yung handout nyo, legal med, and then micro. Okay, may exam mistakes sa pato, tig-dalawang mistakes sila sa biochem. So we're improving. Okay, kaya nagkaroon ng version 2 nang wala sa oras yung micro handout ninyo. The PrevMed handout has already been released. It's now available in the Top Notch portal. Okay, I also gave instructions na yung mga video lectures already available. Some of the PrevMed lectures already available to make it available na. Doc, bakit ngayon lang ni-release yung PrevMed handout na yan? The answer is easy. Ngayon lang natapos ng mga teachers ninyo at ng media team yung editing yan. You may be thinking, Doc, hindi ba dapat ginagawa na yan 2 months, 3 months before? Dapat. But ang all the teachers, kahit bigay mo sa amin ng 3 months yan, we're going to work on it every day and we're going to release it only mga 1 week before. Kasi ino-OC nila bawat ano yan every time So I understood that. You will understand that once you become teachers. So apologize if you have to release it the day before talaga, the night before. Okay? We also did that to minimize yung possible errors. Medyo in-off din naman ng lahat ng mga tao yan. Already gave them feedback on what to do for further improvements. So the PrevMed handout will be handled by a team. Okay, I'll give the intro by tomorrow. So thank you so much. You have a very good teacher with you. Dr. John Borbe is one of our best teachers in Top Notch. Also one of the most decorated. Basically, the valedictorian ng board exams niya, the top one, ng March 2019. Jan, no? Okay, former top-notch student also, graduate of UST, graduate of PGH, okay, currently a gastroenterologist in training. So, Jan, I give the floor to you. Just order coffee and dinner na lang. Okay? Ingat.
Thank you, Doc. Thank you, thank you. Okay. Sige, let me just share my slides. There you go. Sige. Okay, sige. So visible naman, sir, kita naman, no? Before we begin. Doc Ilan. Sige. Okay, sige. So we have a lot of things to discuss tonight. So a lot of these things are very familiar with you already. So hopefully while we're discussing them, it already rings a bell, maaalala niyo na sila, and to reinforce whatever we've learned in the past few days. Okay? Sige. So let's try to remember as much information as we can. And later on, of course, if you have questions, feel free to raise them. Sige. So of course, yan. Okay, so ito mag-start muna tayo sa pinaka-basic uli, no? So talking about the gram-positive cell wall, comparing it to the gram-negative cell wall. So punta tayo sa gram-positive, no? Over here, you can see that there is a very thick layer of peptidoglycan, which you don't see in the gram-negative cell wall, di ba? Sa gram-negative, very thin lang yung layer ng peptidoglycan. Mukha siyang sandwich, di ba? Parang may bread sa taas and in the middle, parang may keso, di ba? Parang may cheese. Okay, so that's the basic structure of your gram-negative cell wall. So another key feature here sa gram-positive, meron tayong mga nakausli na ganito. Ano sila? These are your teichoic acid, no? So pag tinanong tayo sa exam, no, what would be unique sa gram-positive cell wall na wala sa gram-negative? So that would be your teichoic acid. Tingin ka naman sa gram-negative na cell wall, meron siyang mga nakausli na ganito, right? So those are the lipopolysaccharides. And that is something unique to the gram-negative cell wall naman, right? Tignan mo, wala tayong nakikitang ganyan sa gram-positive cell wall. Okay? So nakita na natin yung periplasmic space. We were able to explain that earlier. So sabi natin, pag gram-negative, mas wide yung periplasmic space and it's more prominent. So therefore, going back to this table, sa gram-positive, the peptidoglycan layer is thick, it's multi-layered, you have the teichoic acid, and you do not have the periplasmic space. Okay? So unless siguro sa exam, unless sobrang specify talaga niya na for gram-positive, it's very thin, it's inconspicuous, yung mga ganong terms, no, na parang seemingly driving you towards that answer na dinedefine na niya talaga. So maybe that's the time that you would answer na meron pero manipis. Okay? But otherwise, answer natin is none or absent. Okay, so yung cell wall natin would be composed of two main, the NAG and the NAM, no? Para silang alternating lang, and they are linked together by your peptide bridges, no? Yung peptide bonds natin. So you have the carbohydrate backbone linked together by your peptide cross bridge, and this is through the transpeptidase enzyme. Okay, so sa gram-negative cell walls, no, ano pa yung unique sa kanila? They have, sabi natin, di ba, they have the lipopolysaccharide, which consists of the lipid A and the O antigen. Why is this important? This actually contributes to the pathogenesis of the organism, okay? Because this one triggers induction of IL-1 and TNF, which accounts for the inflammatory response, di ba? You know that IL-1 is one of your cytokines during an inflammatory reaction. It accounts for the fever, yung mga symptoms na nakikita natin. Okay, on the other hand naman, no, sa dakong gram-positive bacteria naman, they do not have endotoxins in general. And the exception here is your listeria. Okay, so tatandaan natin yung mga exceptions because of course, they make good exam questions, right? Okay, so ito yung tanong natin na sinagot na natin. Which of the following organisms lack membrane spherules? So Staphylococci. So to clarify, no, medyo nalito ata ako dun or mali yung nasulatan ko na part, no? So which of the following organisms lack membrane spherules? So the answer is Staphylococci because your mycoplasmas, they would have spherules. Okay? So move on tayo. So let's compare exotoxins and endotoxins. So yung mga gram-positive natin, they produce exotoxins. But the endotoxins, gram-negative siya mas associated. Okay? Pero bakit ganun? Baka may malito. Kala ko ba sa exotoxin gram-positive, bakit yung question gram-neg yung pinag-uusapan? Okay? Because exotoxins are produced by both gram-positive and gram-negative bacteria. Pero yung gram-positive, they do not produce endotoxins. Okay? So kumbaga, mas characteristic ng gram-positive yung exotoxin. Okay? Because kumbaga, the reverse is not true. They do not produce endotoxins. Okay? So yung mga ganyang bagay, medyo for exam purposes na we need to choose, kumbaga, the best answer, the pinaka magri-ring a bell, parang ganun. Okay? So exotoxin, nasa pangalan na exo na re-release. So yes, they are secreted from the cell and they are polypeptide in structure, whereas pag endotoxin, they are the lipid component, no? The lipid A component of the lipopolysaccharide. Okay? And one more thing that I want to emphasize in this table would be the antigenicity. So exotoxins tend to be very antigenic while endotoxins are not antigenic. So isipin nyo na lang dito yung example natin. So say for example, sepsis, no? May pasyente tayo, nagsa-septic shock. For sure, when you were interns, nasa hospital tayo, ang dami-dami nating na-encounter na patients na nagsa-septic shock, correct? So, maiisip nyo, bakit sila nagsa-septic shock? Wala bang bakuna para doon? Wala, right? Wala naman tayong vaccine na magpre-prevent ng septic shock caused by any particular bacteria, right? So, simply because they are poorly antigenic, therefore we cannot make good vaccines out of them. Okay? Because in order to create a good vaccine, it has to be antigenic. Okay, move on tayo. So itong table na to, no, this would just highlight the key features of your organisms. So kapag gram-positive cocci clusters ang pinag-uusapan, catalase positive, coagulase positive, yung pinakasikat, of course, Staph aureus. In terms of the coagulase negative organism, dalawa yan. Coagulase negative na catalase positive, sino iisipin natin? Either yung Staph epidermidis, Staphylococcus saprophyticus, among others. But the key difference is the novobiocin sensitivity. So kapag novobiocin sensitive, that's epidermidis at ang resistant is saprophyticus. Okay? So naalala natin, di ba? Staphylococcus saprophyticus has an intrinsic resistance against novobiocin. Okay? And Staphylococcus saprophyticus, yung nagkakos natin ng honeymoon cystitis. Okay? Naalala ko sa amin before, parang ang daming questions about, what do you call this? Ang daming questions about urinary tract infection. Sometimes, lilito-lituhin ka, pero at the end of the day, if you're sure of your answer, isagot nyo lang. Diba? Huwag tayo magpapadala dun sa fact na, huwag tayo magpapadala dun sa fact na porque, tawag dito, paulit-ulit ko na siyang sinasagot, no? Tapos hindi, baka mali yung sagot ko kasi bakit yun pa rin yung sagot, no? So if you're sure of your answer, so go ahead. Okay? So I'm sorry, give me just 1 minute. I have to take a very important call. I'm sorry. Okay, so let's move on to the next slide. Okay, so how about for cocci in chains naman? Okay, so yung mga streptococci, they are catalase negative. At kapag alpha hemolytic yung pinag-usapan, yung choices natin dito would be si viridans or si Streptococcus pneumoniae. Tama? Pero how do we differentiate them? So you look at bile and optogene sensitivity. Okay? So ang palatandaan ko dito yung optogene, di ba? Meron yung other name. May code name yan, di ba? Taxo. Di ba? Ganun sila. So kapag sinabi natin optogene, that's your taxo P. Parang code name, no? So yung taxo P, that's optogene. Yung letter P, pneumoniae, siya yung sensitive. Okay? So optogene resistant, that's your viridan streptococci naman. In terms of the beta hemolytic, so you have your strep agalactiae and your strep pyogenes, right? How do we differentiate them? You look at bacitracine sensitivity. Si bacitracine naman guys, no, ang code name naman niya is taxo A, di ba? So yung second letter, pag di niyo maalala, optogene, the second letter is letter P. Si bacitracine naman, taxo A, the second letter is A. Okay? Kung sino yung taxo na blank, example, taxo A, siya yung sensitive. So it's your group A that is sensitive and your group A streptococci is your strep pyogenes. Okay? So klaro yon, no? So move on tayo. So how about for bacitracine resistant? Of course, sinabi na natin, yung isa, Streptococcus agalactiae, and yung mga gamma hemolytic, marami sila. Example, group B, Streptococci. Dito ay parang word of caution lang. Don't be confused kasi a lot of different references would classify the other Streptococci differently. No? Meron pa tayong mga group C, group D, E, and F, and G. Magulo na yon, no? But for exam purposes, ikot-ikot lang naman yan sa group A, group B, and then the group D, Streptococci. Okay? So ako personally, I don't pay too much attention sa classification ng iba kasi baka confusing lang sila. Okay? These are the more medically important streptococci naman. So we can focus our attention on them. Okay, so punta tayo sa gram-positive naman kapag aerobic non-motile boxcar. That's your buzzword over there. That's none other than Bacillus anthracis. Reheated fried rice, Bacillus cereus. But of course, dapat tatandaan natin, there are two types of Bacillus cereus. It's your emetic form, 'di ba? Tawag dito, tsaka yung diarrheic form, no? So kapag reheated fried rice, it's really more of the emetic form that we're talking about. Okay? So between the emetic and the diarrheic form, sino ba yung mas shorter ang incubation time? Syempre yung pagsusuka, 'di ba? Isipin niyo na yung sarili niyo, 'di ba? When you eat out in a restaurant and then sometimes even on the way home, you already start feeling funny, 'di ba? Yung parang tiyan natin parang may mali, parang alam mo na may nakain kang hindi tama, right? The first thing na mangyayari is magsusuka ka naman bago magtatae, di ba? So that's a marker of toxin-related na infections, di ba? Yung pagsusuka. Okay? So Bacillus cereus, more of vomiting kapag reheated fried rice yung pinag-uusapan. Okay? And then you have the diarrheic form. Tennis racket-like, that's none other than tennis tetany. Okay? So Clostridium tetany. Bulging cans, no? Bulging, what do you call this? Canned goods. So that's none other than Clostridium botulinum. Lecithinase positive. Ito, very important buzzword as well. Anaerobic na lecithinase positive, causative agent of gas gangrene, that's your perfringens. And lastly, causing pseudomembranous colitis associated with pseudomembrane formation, that's your Clostridium difficile. Okay? So next, non-spore forming naman. So wag malilito kanina spore forming. So guys, ito yung gusto ko rin emphasize. Minsan, yung description pa lang, alam niyo na yung sagot. Kasi kapag spore-forming gram-positive rods, dalawa lang naman yung medically important dyan, either Bacillus or Clostridium. So you can already narrow down your differentials. Pwede ka na mag-X doon sa choices natin, right? But kapag non-spore-forming na gram-positive, sila yung mga Listeria, Corynebacterium, Erysipelotrix. Okay? So yun yung mga choices natin. Let's try to answer. Aerobic, non-motile curve Chinese characters. So you have Corynebacterium diphtheriae. Kapag aerobic curve with a tumbling motility, that's none other than your Listeria. Okay, so later pag-usapan natin in more detail. So pag-usapan lang natin yung highlights or the key features of each organism, no? So si Staphylococcus aureus, you might have heard of this organism in your pedia because mas characteristic yung feature na to in pediatric S. aureus pneumonia, no? Yung pneumatocyl na tinatawag. Although, this is also found in your Harrison's. So kung dito lumabas sa micro, pwedeng sa pedia, pwede rin sa IM. So sulit na sulit ang pag-aaral natin. Okay, it's also among the common causes of post-viral pneumonia course, you know that if you have a viral pneumonia infection, it weakens the immune system, especially in the mucosa, di ba? Nagda-damage yung mucosa natin, epithelium. So nagkakaroon na higher risk to get secondary bacterial infection. Okay, so this one I also want to emphasize, no, yung osteomyelitis, because osteomyelitis in Staph aureus differs in presentation in children compared to adults. No, in children, more common yung involvement ng long bones. How about in adults? More of vertebra naman. Okay, so this one, acute and chronic, pwede tayong tanungin, no, how do we treat acute osteomyelitis? How do we treat chronic osteomyelitis? Again, this one, word of caution, the treatment is actually much more complex than what I presented here. Okay, so pag tinignan natin sa Harrison, sobrang daming table niyan, iba-ibang antibiotic. But in general, when we talk of acute osteomyelitis, they can be treated with long-term antibiotics. So sa choices, maghahanap ka ng weeks. No, never ka makakakita ng osteomyelitis na treat for 7 days. Di ba ganun yung standard natin pag di mo na alam, complete 7 days antibiotics. Di ba? Laging ganun. But for osteomyelitis, remember, it's usually a long time, no? Lalong-lalo na for chronic osteomyelitis, if you cannot remove the hardware, no? So, lalo-lalo na yung mga may prosthetic devices, yung mga may bakal, usually you need to remove them. Okay? Surgical drainage and removal of dead bone. Sa acute osteomyelitis, hindi natin kailangan remove yung hardware, di ba natin kailangan ng surgical drainage? Like I said, in some cases, kailangan pa din. This is just a generalization, oversimplification for exam purposes. Okay? Brody abscess, you see it in the metaphysis of the long bone. It's a sequestered foci of osteomyelitis. Tandaan na, no? So, Brody abscess. Toxic shock syndrome, head to toe, no? So, tingnan natin yung babae dito sa picture natin, di ba? Head to toe yung manifestations. Meron din siyang rashes, meron siyang diarrhea, GI symptoms, nagsha-shock pa siya. So, you have a desquamating rash that follows the initial presentation. Okay? So, in toxic shock syndrome caused by Staph aureus, usually you don't have a focus of infection. Okay? Walang site of pyogenic inflammation. As compared to toxic shock syndrome that's caused by streptococcus. That's why in some cases, we call it toxic shock-like syndrome. No? Si streptococcus. Okay? Another differentiating feature, blood CS negative for Staph aureus. Ang toxic shock syndrome ng strep is blood CS positive usually. Okay? So usually you see it in settings na meron kang good media for cultivating the organism. So example, women who are using tampons, people who are have epistaxis na nagne-nasal packing, di ba? So like I said in lecture, di ba, imagine niyo na lang na para siyang culture media. Di ba? So yung tampon na yon, yung nasal packing na yon, it serves as your culture media. Mainit yung katawan, para kang naka-incubator, para kang may culture media. And that's it, no? You have a fertile environment for toxin production. Okay? So ito na, no? So we summarized this in this table over here. So kapag staphylococcal, you have the TSST1 as the culprit. For streptococcus, you have the pyogenic exotoxin A or the EXO-A. Okay? So tatandaan natin yung mga key differences na yan. Okay. So Staphylococcus epidermidis, no? So you have this organism that adheres to foreign bodies, prosthetic devices because of its ability to form biofilms. So question, overall, no, sino pa yung pinaka-common na nagko-cause ng infectious endocarditis? It's still Staphylococcus aureus. Okay? Lalong-lalo na sa mga injection drug users, no? So automatic yan. Pag narinig nyo injection drug users, think of Staphylococcus aureus. But overall, no, it's still Staphylococcus aureus. Baka may na-confuse, Doc, bakit ganun? Nag-aaral ako ng iba-ibang references. Bakit sabi sa reference na to, Staph epidermidis daw yung most common? Okay, so I understand the confusion kasi especially in the older editions of textbooks ng micro, they would often say Staph epidermidis is the most common cause of IE, infectious endocarditis, infective endocarditis. But that is in the context of somebody who has prosthetic heart valves, okay, or prosthetics, no? But even then, no, some series would say that Staph aureus pa din yung pinaka common. Okay? So you have to read the question very well. If the question is alluding to IE in the setting of prosthetic heart valves, no, in the setting of a patient na pwedeng magkaroon ng biofilm production, no, so you answer Staphylococcus epidermidis. But when we're talking of IE in general, No? So especially in injection drug users, tough or use pa din yung sagot. Okay? So again, oil tuloy. It all boils down to context. Okay? Lagi ko nga sinasabi sa mga students, you have to put yourself in the shoes of the examiner. What is the examiner trying to ask me? Yes, may ganung reflection. No? Ano bang tinatanong niya? Ano bang gusto niyang sagot? 'Di ba? Kasi minsan, tawag dito, alam mo kung ano yung ina-allude niya, 'di ba? Parang it's trying to make a point, 'di ba? Mafe-feel niyo yan if you practice and practice answering questions. Streptococcus pyogenes, yung important na gusto ko emphasize would be the immune sequela. There are two main types. You have the acute rheumatic fever and glomerulonephritis. So what would be the major difference? No? So for glomerulonephritis, you have it can follow skin and throat infections, but for rheumatic fever, it follows pharyngitis only. Naalala niyo sabi ko ganun, pababa, 'di ba? Throat infection, saan malapit? Sa puso, pababa. Okay? So rheumatic fever only comes from post-pharyngitis. Okay? So what else is important here? Acute rheumatic fever can be reactivated, and that is the reason why you need chemoprophylaxis. Okay? And that's also the reason why you need to treat, diba? Kasi pwede siyang maulit, no? And accrued or repeated rheumatic bouts of rheumatic fever can cause accrued damage sa puso, especially in the heart valves. Okay? Kaya kapag nag-clinic kayo, nag-auscultate, may narinig, may murmur. You have to elicit in the history, baka may recurrent bouts of rheumatic fever during childhood. But in reality, mahirap siya actually i-elicit. Okay? Move on tayo. Clostridium tetani, terminal spore, tennis racket appearance. Right? So look at the picture. Nasa dulo siya, di ba? Because some of the Clostridia are subterminal. Guys, magkaiba yun, ha? Huwag malilito. When you say subterminal, it's just below the end, no? So kung ito yung end, nasa medyo ilalim ng konti, no? So they can be subterminal. Pero pag Clostridium tetani, nasa dulong-dulo talaga siya. That's why it looks like a tennis racket. Okay? So lahat ng anaerobic organisms, isipin nyo na yan, generally, the treatment should be to do debridement. Okay? You need to remove the vitalized tissue. You need to remove that fertile ground for which the organism, produces the spores. Okay? So yun yung pinaka-important talaga. So treatment, metronidazole or penicillin. Baka may nagbabasa ng multiple references, malito, Doc, nagbasa ako ng Harrison. Sabi doon, the preference is to use metronidazole. That is correct, no? Pero pag walang metronidazole sa choices, we can answer already penicillin. Okay? For micro board exam purposes, guys, no, penicillin would suffice as an answer na, no? Kasi wala namang specify si Jawets kung metro or penicillin, but for IM, metro yung isasagot natin. Okay? Bakit? Because sabi ni Harrison's, no, penicillin in theory can cause exacerbation of the spasms in patients with Clostridium infection. Okay? It's because of the effect on GABA. No? Kung naalala niyo in pharmacology, di ba? It has an effect on GABA. Okay. So, eto na, yung review lang natin, no? Yung how do we vaccinate, no? Do we give the toxoid or do we give the immune globulin, no? So, minsan, iba-ibang brands yan. Baka malito din tayo. Minsan kasi pwedeng brand yung ibigay sa inyo eh. So, like yung Teana, no? Na name or yung mga Tetagam, no? So, in general, no? Kapag nagkaroon tayo ng pag nagkaroon tayo ng injury, no, that would be the portal of entry for the spores to enter. If you were already vaccinated, no, meaning to say you were able to receive 3 doses of the tetanus vaccine before. So generally, you don't need to receive either the toxoid or the immune globulin. Okay? So ganun ko memorize yung table. Diba? Parang you're trying to analyze it. So regardless of the nature of the injury, whether it's clean, contaminated, regardless, no, you don't give the toxoid or immune globulin. Unless, diba? Mas madaling tandaan yung exceptions eh. Unless the last dose is already more than 10 years or more than 5 years. Madali namang tandaan, more than 10 years kapag clean wound, kapag contaminated, mas mag-iingat ka, diba? So more than 5 years lang. So shorter yung duration ng years, di ba? Kasi mas maingat ka kapag contaminated, right? Kasi higher risk to get the spores. So that's how I try to remember it. So how about if uncertain? If uncertain, you treat it as if you're not vaccinated. Ganun mo lang siya isipin. Therefore, I need to get vaccinated. But what type of vaccine should I get? Kasi nga, hindi ako sure eh. So you get both kapag contaminated. Kasi sabi nga natin, higher risk. Hindi ako sure na nabakunahan ako. Higher risk kasi contaminated yung wound ko. So you get everything, di ba? And also, ang caveat nandito is kapag walang binigay na history, hindi sinabi sa question na nabakunahan, hindi rin sinabi na hindi nabakunahan, the nature of the wound was not described adequately, the best answer pa din is to just give both. Okay? So that's the assumption. If there is no descriptors in the question, the assumption is contaminated yan and hindi yan bakunado. So you give both. Okay? The same goes in actual practice in the ER. Kapag hindi sigurado si patient, we just give both. Okay? Move on tayo. Okay, so this one, no, just to highlight the different manifestations. So you have the opistotonus, the arching of the back. You have the risus sardonicus, no? So yung the devil's grin, ito siya. You have trismus or lockjaw, one of the first manifestations, no, lockjaw. And autonomic instability. Tatandaan yon ha, kasi a lot of students just focus on the muscle spasms. They forget the autonomic instability that happens with tetanus. What you call the dysautonomia. Okay, so minsan, okay, biglang siya shoot up, biglang mag-hypotension, yung heart rate, very labile. Okay? So you need to remember that as well. Kasi baka mamaya, yung question, hindi masyadong mag-emphasize on the spasms, right? Okay. Kapag Clostridium botulinum, it's the exact opposite of your Clostridium tetani in the sense that kung si Clostridium tetani, spastic na paralysis, no? Flexed. Si botulinum, relaxed. Okay? Yung baby, para siyang very limp, no? That's why you call it the floppy baby syndrome. So it's also paralysis, but this time it's flaccid paralysis. So floppy, walang muscle contraction. Okay, preferences sa pag-usapan na natin, gas gangrene. Kung meron ako isang papatandaan dito na hindi pwedeng kakalimutan, taga sa kaluluwa, the alpha toxin lecithinase. Okay? So just remember, that's a very important virulence factor for your Clostridium perfringens. Tandaan na ngayon, alpha toxin, you have your lecithinase. So other than causing gas gangrene or infection through the wound, you can also have food poisoning. Yung the usual run-of-the-mill food poisoning. Okay, not as dramatic as gas gangrene caused by perfringens. Treatment, ito na naman, no? Basta anaerobic yan, no? Kailangan ilinisin natin yung wound. You need to remove the devitalized tissue, you need to remove the fertile environment for growth. Kapag food poisoning, sabi ko nga, di ba, it's not so remarkable. So, supportive management. Okay, so kwento ko lang no before we move on. So kapag food poisoning, no? So kapag may mga pasyente na na-food poison, no? Tapos, especially if you're a budding moonlighter or a budding GP. Ako kasi yun yung ano ko, tao dito, yun yung hindi naman pagkakamali, pero yung nakasanayan na practice, di ba? Na kapag nagda-diarrhea, tapos yung pasyente nasa ER, parang reflex na okay, IV line, ganyan-ganyan. Paubusin natin yung IV line bago umuwi yung pasyente. Pero come to think of it, it's really just supportive, di ba? So if your patient is able to drink, your patient is, conscious, wala namang signs ng severe dehydration, you can actually send them home, just reassure them, di ba? Check lang natin yung fecalysis na it's non-bloody, na non-mucoid, baka pala, no? Dysentery pala na might have to be admitted, no? But if it's the run-of-the-mill, nagva-vomit, no? So you don't really need to admit them. Ako kasi dati naalala ko na talaga, oh my God, kailangan ko silang sweruhan. Tapos gusto na umuwi ng pasyente, nagpapanik ako. Sabi ko, oh my God, kailangan na maubos yung swero. I-fast drip natin, ganyan, di ba? Kasi pag ikaw na yung doktor na humaharap talaga sa kanila, laging tanong ng pasyente, Dok, kailan mo ko sweruhan? Di ba? Tapos pag di mo sila swineruhan, their impression is always na, oh my God, I'm in a hospital and I'm not getting my IV line. Oh my God, di ba? As interns nga, kapag yung swero, di ba, hindi tumutulo, nagpapanik agad sila na, Doc, yung swero, hindi tumutulo. Parang end of the world, no? So you just need to reassure them. So, balik tayo sa totoong buhay, the management for your run-of-the-mill cases of food poisoning, it's just supportive. You don't need to really to give antibiotics for this. Okay, so sa difficile, you have your exotoxin A and B, and that is also the reason why your diagnostic tool for this is your antigen testing, stool antigen test that would detect both your exotoxin A and the exotoxin B. Okay? So, punta naman tayo kay listeria. ano ba yung very unique kay Listeria? It has a tumbling motility, no? Parang end-to-end yung pagtatumbling niya. Because paano ba? Paano natin i-demo yan? So example, ito na lang, no? My nasal spray for my allergy. Naka-blur pala. Pero nakikita niyo naman yung outline. So, di ba in other organisms, di ba yung Giardia, it's like a falling leaf motility. For Listeria, it's end-to-end, no? So, tumbling end-to-end, no? Dulo to dulo. Nag-make sense ba yung pagdedemo ko? Parang hindi rin, no? But at least naalala natin na tumbling motility, you think of Listeria monocytogenes. Okay? Another thing, it loves cold environment. And also, it follows that if it loves cold environment, saan mo siya makikita? Sa malalamig na pagkain. Coleslaw, salads, cheese, milk, dairy products. Okay, so yun yung mga clue natin sa exam, no? Pag narinig natin yung mga ganun, malalamig, nire-ref. Coleslaw, salad, no? So you think of Listeria. Okay? What if naman yung mga creamy, spaghetti, lasagna, na pwedeng pagtubuan ng toxin? Usually that's associated with Staph aureus, no? Yung mga mamayo na pagkain. Okay, sige, move on tayo. So this one, let's try to differentiate nocardia and actinomyces. One is aerobic, one is anaerobic, one is weakly acid fast, no? So si nocardia is weakly acid fast. And for tissues, we often use the fight Faraco or kahit anong may fight, no? So Wade fight Faraco, modified fight, di ba? So basta may fight, you think of AFB stain. Okay, acid fast stain yan. So nocardia, they produce orange colonies, while actinomyces, you look for those yellow sulfur colonies. In terms of treatment, eto, again, don't be confused. So this is just a generalization, no? So meron tayong acronym na SNAP. Sulfonamides, like cotrimoxazole for nocardia, and actinomyces, you can give penicillin, okay? But again, this is not an all-encompassing treatment, no? That's the difficult part siguro sa treatment ng micro, because sometimes, no, sa micro, they just give general na recommendations. But remember, at the end of the day, you need to read through the question, read through the choices, and pick the most appropriate choice of drugs. Okay? So at least you have an idea. Yun naman yung gusto natin point out dito, yung class of drugs that we use. Okay, so if you already have an example, kung wala man yun sa choices, you can think of sino ba yung kamag-anak ng gamot na to? Sino ba yung kalapit ng gamot na to? Okay? Okay, so this one, just emphasizing, so ito na-miss out natin before, no? Sa maltose utilization ng Neisseria meningitidis, positive. Natandaan nyo lang yung letter M. Okay, maltose meningitidis. Gonorrhea, anong i-utilize niya? Glucose. Diba? G to G, M to M. Okay? So, yun, ha? So, si gonorrhea, it does not utilize maltose. Si Moraxella, not so associated with a lot of diseases naman si Moraxella. But a very important thing about Moraxella is it is asaccharolytic, meaning to say it does not utilize any sugar, no? So asaccharolytic si Moraxella. So negative dito sa table natin. Okay? The rest we will go through them as well as we go along. Okay? So gram-negative diplococci, ano nangyari? So si gram-negative diplococci, you have either Neisseria nga or si Moraxella. So, sabi na natin, no, kapag glucose lang, gonorrhea. Pag maltose in particular, you think of meningitidis. But it also ferments glucose. Okay? Pero ang hahanapin mo sa exam is the ability to ferment maltose. Okay. It has a polyrebutyl phosphate capsule. Sino kaya ito? Sino yung maarteng organism na to na gusto chocolate agar? That's your Haemophilus influenzae, serotype B. Whooping cough. Whoop. Merong inspiratory whoop. Okay, that's your bordetella pertussis. And sino kaya itong nakikita daw sa air conditioning units? We can culture using the buffered charcoal yeast extract agar. Answer, Legionella pneumophila. Okay, so they are poorly gram staining. That's why we use silver stain. Okay. If not silver stain, you can use other stains as well. Okay, so some references would also say it's partially acid fast. No, you can use that to visualize the cell wall of Legionella. Okay, because it's not so obvious. Okay, punta naman tayo sa mga non-lactose fermenting. No, so sino ba yung mga maiisip nyo pag non-lactose fermenting? Na-mention natin to, di ba? Yung SSPPM, no? Salmonella, Shigella, Proteus providentia morganella. Magkakatunog sila, kaya madaling maalala. Salmonella Shigella, Proteus providentia morganella, SSPPM. Okay, so tandaan na. H2S producer, Salmonella yan. Non-H2S producer, Shigella. Okay? Do remember those key defining features. Sabi natin, si Shigella tamad, non-motile, negative oxidase, non-H2S producer, does not utilize yung mga kanunong sugar, no? So, Shigella. Swarming, alam na natin agad, Proteus. Okay, so how about this one? Non-fermenter na oxidase positive this time, think of Pseudomonas. Okay? Greenish metallic sheen, sino na nga ito? So habang while we're going through the questions, no, or the features na I want you to try to answer, no, kahit sa sarili nyo lang, para to test yourselves as well, di ba? Tapos pag mali tayo, mas maalala nyo yun pag nagkamali kayo, di ba? Green metallic sheen, sino nga yun? E. coli, urease positive, and commonly ESBL. So that's your Klebsiella pneumoniae. Okay? So yung ESBL na part dyan, no, hindi yan ibig sabihin lahat sila ESBL, no? It's just that majority, no? So notorious na they can be ESBL. Comma shape, oxidase positive, that's your Vibrio. Microaerophilic na comma shape this time, Campylobacter. Okay? So wag tayong malilito dito. So dalawang comma shape, no? So, isa si Vibrio, isa si Campylobacter jejuni. But how do we differentiate them? Si Campylobacter jejuni is characteristically microaerophilic. Okay? So other description for Campylobacter jejuni, it can be described as a seagull or a gull-wing shaped organism. Comma shape na urease positive, you think of Helicobacter pylori, di ba? The urease test, naalala yon, urea breath test. Okay, ito yung bread and butter namin. We always do this every day. H. pylori testing, EGD, endoscopy, tapos kukuha ng sample for H. pylori testing. And that is based on the ability of the organism to produce urease. Okay? So, there you go. So, pag-usapan natin ng mabilis yung mga key points ng mga organisms na gusto kong tandaan natin. Neisseria gonorrhea, habitat is the human genital tract. Transmission is via sexual contact. And what would predispose a patient to have Neisseria infection? It's the deficiency in the late-acting complement component. Tatandaan yun. Okay? And this is not specific to Neisseria gonorrhea, guys. Even Neisseria meningitidis. Pareho sila. Okay? Both of them would be predisposed, no, kapag meron tayong deficiency in the C6 to C9, which is basically the components of your membrane attack complex. Okay? Dito, ang gusto kong tanungin sa inyo, which one of the virulence factors would confer antigenic variation, okay, or distinction in terms of the antigenicity? Tignan natin sa mga nakalagay dito. So the best answer would be the pili. Okay? So naalala ko nagkamali ako dito kasi pag tinatanong to, ever since med school, lagi akong mali. Bakit? Kasi iniisip ko, bakit naman magiging unique yung pilay? Diba? Lagi kong sinasagot, OPA. No? Yung pala OPA, parang wala lang pala siya, mema lang. No? Just confers the opacity, the opaqueness of the colonies. Pero si pilay pala yung star ng show. Okay? Sige. Ophthalmia neonatorium, that's eye infection in the newborn. Take note. When we say ophthalmia neonatorium, that's not just specific for gonococcal infections. Pwede rin sila sa other eye infections in the newborn. Okay? So, hindi lang sa Neisseria gonorrhea yan. But traditionally, classically associated with Neisseria gonorrhea. Okay? Let's move on. Hemophilus naman. Laging tatandaan, Hemophilus clingy, maarte, no? Maarte. Requires X factor, V factor. Ang dami mong kailangan. Nagsasatellite phenomenon, clingy, kailangan niya mag-grow around Staphylococcus or use. Ayaw niya ng simple na blood agar na sheep tawag dito? Sheep blood agar. Gusto niya horse blood agar, no? Bida-bida. So laging isipin Hemophilus sensitive, maarte, no? Sensitive because it is sensitive to temperature changes. Okay, it's easily destroyed, it's easily killed by environmental factors, chemicals, and temperature changes. Okay, so yun yung key feature ni Hemophilus. So ano naman tatandaan natin? It can cause meningitis, epiglottitis, you have the cherry red sign, di ba? Or the thumb sign, I mean. Okay, yung parang leaf. COPD exacerbations in particular, you see this in the non-typable H. influenzae. Ano ibig sabihin nun, no? Non-typable. Di ba usually kapag H. influenzae, ano sila? Yung pinaka-common na na-encounter natin sa patients natin, it's the H. influenzae serotype B. Di ba? Kaya nga yung bakuna natin, Hib. It's talking about the serotype B. But the B, no? We call them in general the non-typable. Pinag-lump together na lang natin sila because you're not special, di ba? So sama-sama na lang kayo dyan. So COPD exacerbations is classically associated with those non-typable H influenzae. Okay? Legionella, no? Titanic, no? So isipin natin cruise ships, cooling towers, Iwata, di ba? But as I mentioned in the lecture, it's actually overemphasized. Okay? Pero syempre, di ba, hindi naman nagbabasa ng libro yung mga board examiners. Do you expect them to read, di ba? Tayo nga, hindi nagbabasa. Sila pa kaya. So, probably yun pa rin yung alam nila. No? So, kapag sinabi nila associated with cruise ships, cooling towers, you think of Legionella. Okay? Pero ano nga yung tama? Saan daw sila mas nakikita? In the context of aspiration. Okay? So, ulit, saan sila kinoculture? Kaya ko to, no? Nabubulol na. No, kasi mula umaga kanina pa ako tuloy-tuloy, no? Galing akong hospital. Wala pa akong oral intake. Okay, anyway, so you have your buffer charcoal yeast extract. Urine antigen testing is unique to Legionella. Si Strep pneumoniae, may ginagawa na rin tayo dyan na urine antigen testing. We also do it for Strep pneumoniae, but more typical, no? Pag isa lang yung pwede isagot sa board exam, Legionella na yung isagot natin. Okay? So it can replicate intracellularly. And cell-mediated immunity here is very important, no? Yung T-cell-mediated immunity natin. Okay? So you have two main types of infection. You have the atypical pneumonia. No? Of course, ito yung mas serious. Pontiac fever is the mild self-limiting na inuuwi lang natin. No? Antibiotics is not required. What's unique about Legionella pneumophila infection is that it is associated with diarrhea and hyponatremia. Okay? Confusion as well, no? And high fever. Dami ko sinabi, no? May table kasi yan sa Harrison, sa alala ko, nag-exam kami sa IM, tinatanong, ano yung mga features ng Legionella pneumophila? Diba? Kasi guys naman, kung binigyan kayo ng case about pneumonia, fever, cough, dyspnea, pare-pareho lang yan. The list of your differentials can go on and on and on. Sobrang dami, right? So yung board examiners dyan, usually magbibigay lang yan ng isang distinctive feature. Sabihin niya, fever, cough, dyspnea, tapos ay, nag-diarrhea din pala. Sodium 128, sodium 125. May confusion din pala. Alam mo na pag ganun, it's Legionella pneumophila. Okay? So, kailangan minsan medyo piloso po ba yun? What do you call this? Sa exam, minsan hindi ka dapat nag-overthink. Lagi mo lang isipin na what are we being asked? No? Ano yung concept na tinatanong sa atin? Yung defining features ng Legionella. Parang ganun. Okay? So, E. coli. So, iba-iba yung mga E. coli natin. ETEC. Watery diarrhea, EPEC, pathogenic diarrhea. You see this usually sa mga infants. Okay? Not just infants, no? Pati yung mga home for the aged, lolo, lola. Okay? EHEC, enterohemorrhagic E. coli. So you have the hemolytic uremic syndrome. Enteroinvasive, nasa pangalan na invasive. So it's bloody diarrhea. Enteroaggregative. What's interesting, it's associated with patients with HIV. Okay? So si Salmonella, no, emphasize natin to. Salmonella, ano nga yung predominant symptom? Fever, okay? Prolonged fever is the key feature of Salmonella. After the fever would be abdominal pain, okay? Diarrhea and constipation can occur, so hindi tayo maghahanap ng diarrhea, okay? For me, ito yung isa sa mga pinakamahirap na questions, yung mga about diarrhea. Baka kasi pag binigyan ka ng diarrhea, goodness, no? Sobrang daming pwedeng differential, no? Head to toe yung differentials natin in terms of the list ng mga pwede natin isipin na organisms, right? So you need to look for other defining features. So for example, for Salmonella, ano ba yung hahanapin nating unique thing? The salmon-colored spots, which you call the rose spots, right? What else? The step ladder fever, na pataas yung fever natin. Yun yung mahahanapin natin. What else? By the 3rd and 4th week of illness, you can actually have what do you call this? Bleeding, perforation of your terminal ileum because, you know, the typhoid fever, Salmonella, actually multiplies in the Peyer's patches. Okay? And usually that happens by the 3rd and the 4th week of illness. One more thing, Salmonella is associated with confusion states, no? Yung tinatawag nating coma vigil, parang vigil. Sige, kaya ko to. Yung parang nagpe-pray, yun na lang sinabi niya. Nagpe-pray. Di ba yung example, you have the rosary, di ba parang nagaganon. So parang ganun yung itsura nila, di ba? Kasi parang they do this with their hands. No, there's really no defined pathophysiology behind it, but it's something unique for Salmonella. Okay? They pick on the bed sheets, no? So yun. So you think of Salmonella pag may ganun. And kapag merong neurologic manifestations, most likely that's Salmonella. Okay? So Salmonella, hindi lang naman lahat ng Salmonella typhoid fever. Okay? It can also cause your run-of-the-mill enterocolitis. So you're not so severe form, no? You don't have the prolonged fever, no? So septicemia, typically associated with Salmonella cholerae. Okay, common among those with sickle cell anemia. Si Shigella naman, no? Very similar, na-mention na natin itong mga features na to and associated with the 4Fs, food, fingers, feces, and flies. So si Shigella, ano yung features natin? The same, abdominal pain, diarrhea, but the neurologic manifestations for Shigella would be distinct only for Shigella dysenteriae. Tatandaan yun. Okay? Marami kasi iba-ibang Shigella, di ba? You have Shigella boydii, Shigella sonnei, Shigella flexneri, but it's your Shigella dysenteriae that would be associated with neurologic manifestations. Okay? So Vibrio tayo, comma-shaped na gram-negative rod, oxidase positive. And pag tinanong tayo, no, kung may tatanong ng culture media, pwedeng Vibrio kasi very unique, di ba? TCBS, no? Your thiosulfate citrate, bile salt sucrose agar. Ako, I don't encourage you to memorize all of the culture media on earth. No? Naalala ko na medtech kami, ilang pages yan. Diyos ko Lord, tatanungin tayo talaga lahat yan. But for board exam purposes, tandaan pa din natin yung mga mas unique, yung mga mas distinct, like this one. Kasi who knows, pag tinanong, 1 point din yun. Sa board exam, bawat puntos mahalaga. Okay? So, Vibrio, no, iba-iba ng route. No? May nagtanong na student kanina, Doc, no? Ang Vibrio vulnificus ba mas sa shellfish? Hindi ba yan nakukuha sa mga seafood? Vibrio parahemolyticus ba sa seafood lang? Let's clarify. Vibrio parahemolyticus, you get it from seafood, no? Sea creatures, no? So, yon. Vibrio vulnificus pwede rin. But classically associated with shellfish. Either through trauma, either through skin contact, or even through ingestion. Okay? So, klaro yun, ha? So, example, yung oyster. Alam nyo, buzzword yun. Oyster equals vulnificus, right? So, either handling oysters or ingesting oysters. Pareho pwede. Okay? So, nasa Harrison's yun. Okay, so Vibrio toxin acts by ADP ribosylation. The subunit B is taga-sundo lang. It's the subunit A that really acts. Natandaan nyo yung A, yung type A, siya yung bida-bida. Siya yung nag-increase ng cyclic AMP. Si B, siya yung backup. Diba? Taga-sundo. Okay? So, siya yung nagpo-promote ng entry of your subunit A. Move on tayo. Cholera, of course, associated with your rice water stools and the washerwoman's hands because you lose a lot of fluids. Nagkukulubot na yung kamay. Okay? So, complications, pwede magkaroon ng renal failure, heart failure, and what do you call this? Multiple electrolyte imbalances, and they can die from that. Campylobacter jejuni, na-mention ko na yung seagull shape, and it's among the most common causes of bacterial gastroenteritis. Okay. So, si Campylobacter jejuni, hindi naman siya ganun ka-special, no? But you know, it's associated with Guillain-Barré syndrome, right? Yung GBS. Okay, and it can also mimic ulcerative colitis. Okay. So, GBS and reactive arthritis or Reiter syndrome, which is characterized by a triad of urethritis, uveitis, and arthritis. Okay? O may new edition na ng, Jujutsu Kaisen. Ito, no? Sa picture natin, can't see, di ba? So, yon. Huwag na kayo manood, guys, no? Gamitin nyo na lang sa pag-aaral ninyo. Kung may gusto kayo panoorin, tanungin nyo na lang ako kung ano nangyari. Okay? I can summarize in 2 sentences para save tayo ng time. Mag-aral na lang. Next, Klebsiella pneumoniae, urease positive, facultative gram-negative rods with large polysaccharide capsule. Okay? So, you have the current jelly sputum. So, yun yung buzzword natin. Okay? So, yun. So, what else? Pag kinulture pala natin siya, because of its large capsule, ano siya? Mabikit. Diba? Slimy, sticky, diba? So, yun siya. Very mucoid colonies. Pseudomonas, of course, in green color. It can be grown on cetrimide agar. What else? It's non-lactose fermenting. And what's distinct about Pseudomonas is the so-called Ecthyma gangrenosum. Yun yung hahanapin natin, ha? Sepsis caused by gram-negative organisms are mostly similar. But if you see Ecthyma gangrenosum, that is a clue, no? Na baka Pseudomonas ito. Okay? So yun yung sinasabi ni Harrison sa atin. Doc, bakit ka gumagamit ng Harrison's and Jowetts, di ba, ang reference natin? Because unfortunately, in your board exam, sometimes the micro part is, bordering on IDS already. So whether we like it or not, sometimes we need to go clinical already. Okay? Mapapansin niyo yun. Very clinical na tayo. Okay, so this table, napag-usapan na natin. Ano lang yung mga key differences dyan? Yung pH, sasabi natin pag candidiasis, pwedeng acidic. No? All the rest, no? Usually kapag trichomoniasis and back vag, usually have higher pH. Okay? So review this table na lang. Okay, pag-usapan natin, tinanong kanina, napag-usapan na natin, you have a rough, dry, and buff-colored colony. So what is the most likely organism? That's your Mycobacterium tuberculosis. Okay, so that's choice letter A. The mere fact, guys, no, na it grows after 2 weeks, no, that already tells you it's a slow-growing organism. So your choice should only be A and B. But between A and B, mas mabagal si Mycobacterium tuberculosis. Okay, that's the reason why we keep the cultures for 4 to 6 weeks, right, before we discard it, because sometimes you have slow growers. But remember, di ba, sa mga mycobacterium, you also have the rapid growers naman. And the rapid growers, they are characterized usually as saprophytes. Mga pampagulo, nakikistorbo lang. They're not as pathogenic, of course, as Mycobacterium tuberculosis. So, ayun yung sinasabi nating buff-colored colonies, no? Yung parang flesh na kulay. No, so ito siya. And the culture media on your right, very distinct din. Gusto ko tandaan niyo yan, Lowenstein-Jensen. Very rare na tayo gumagamit ng LJ medium nowadays, no, kasi sobrang tedious. But for exam purposes, LJ medium, tandaan. Disseminated TB and miliary TB, we already mentioned that miliary TB falls under the bigger umbrella of disseminated TB. They look like millet seeds. And when we do fundoscopy, you look for those choroidal tubercles. What is the difference between PPD and your IGRA? So your PPD will test for type 4 hypersensitivity, no? And it is subjected to a lot of false positive and false negative na situations. But one very, very important thing that I want to emphasize here is that it can cause a positive result by prior BCG vaccination. Tatandaan yun, guys. Tandaan na ngayon. So kapag nagpabakuna with BCG, pwede mag-false positive with PPD. Pero sa IGRA, hindi ganon. No? The results are not affected by prior BCG vaccination or infection with a non-tuberculous mycobacteria. Okay? That's why nowadays, the thrust is to move towards IGRA. No? Yung mga nagpi-PPD na lang, yung mga walang TB, yung mga malilinis na bansa, like Germany. I remember when I kwento ko na ba to? Minsan paulit-ulit yung kwento ko, hindi ko naman maaalala na nakwento ko na. Pero uulitin ko pa din, no? So nung pumunta ako ng Germany before, for a quick elective lang naman, I remember they were requesting for the PPD na sobrang barbero lang talaga gawin. If you've seen it before, di ba ini-inject siya dito, the volar aspect, right? So yun. So dyan, ini-inject and then you measure it after 48 to 72 hours, usually 48 hours, no? Pwede na rin 24, but usually most centers 48. We want to measure the induration formation, right? So, paniwalang-paniwala sila sa result ng PPD. Pero like, kung Pinoy ka, di ba lahat naman ng tao na-expose sa TB in the Philippines? Like, national bacteria natin yan, di ba? So, yun. So, yun na lang yung gumagamit ng PPD. Usually for foreign countries, no? Pag nag-a-apply kayo someday, yun. Manonotice nyo yun. Pero ngayon, we are driving towards IGRA na, lalo sa Philippine setting because many of the Filipinos nagbi-BCG vaccination. Move on tayo. Mycobacterium leprae, you have the tuberculoid and the lepromatous. A very quick way to think about this, no? The differences would be just to think of the immune status. Sa tuberculoid, meron pang immune response. Nalilimit pa natin yung infection, so hindi ganun ka marked yung manifestation. Immune-based tests like lepromine test would still be positive kasi meron pang cell-mediated immune response. And the reverse is true for lepromatous. So babalik ta rin natin. Okay? So ganun yun na lang siya isipin. Kung information overload na, hindi na talaga kayang tandaan. Kasi 'di ba, we have to be honest with ourselves. Kung memory capacity ng katabi natin 5 tera, sa'yo 256 lang na MB, wala tayong choice, 'di ba? Minsan kapit sa patalim, no? You have to think of ways para maalala natin yung yung information. Okay? So that's how I analyze it. Okay, next, Mycoplasma pneumoniae, most common type of atypical pneumonia, walking pneumonia. Actually, yung mga ganitong most common, I take it with a grain of salt. Okay? Because sometimes ibang reference, iba ang sinasabi. Okay? So I doubt naman na itatanong sa atin to. Mas itatanong sa atin presentation. So doon tayo magfo-focus. Si Mycoplasma pneumoniae, usually associated with a lot of extrapulmonary manifestation like hemolysis, no? In the setting of a cold agglutinin disease, no? Guillain-Barré syndrome as well. So it's not specific for Campylobacter jejuni. So ito yung sinasabi natin cold agglutinin disease. They would agglutinate during cold temperature and they would disperse at warm environments, no? So paano natin siya ipaprocess? So minsan nag-extract ka ng dugo. Okay, so naalala ko pag even as a resident, I do encounter a lot of patients with cold agglutinins. Wala lang sa literature, but a lot of Filipinos would have this. Pag extract mo ng dugo, no, pagdating mo sa cold room, no, makikita mo yung blood, nagkukumpul-kumpul sila kasi malamig sa cold room. Pero pag winarm mo sila, magdi-disperse, magiging normal ulit sila. Okay, so yun yung cold agglutinin. So that's actually one clue na baka Mycoplasma pneumoniae pala siya. Okay? So pwede yan i-describe sa board exam ninyo. Yung ganong scenario na you're considering pneumonia and then you extracted blood and then pag extract mo ng blood, nagmukhang nag-clump but it disperses upon heating or upon introduction to a what do you call this, a water bath. So yun, ganun siya. So punta tayo sa chlamydia. Yung chlamydia natin would have two bodies, the elementary body and the reticulate body. Puro letter E, infectious, enters the cell via endocytosis, and what do you call this? Extracellular. Okay? Reticulate body replicates, no? And this is the, what do you call this, important in terms of the reproduction nila. Okay? So si chlamydia, clarify natin uli ito. Sabi ko, di ba, pag mga most common, ingat tayo dyan. May mga qualifiers yan usually. So this is, anong sabi sa atin sa libro, most common bacterial cause of STD. Okay? Kasi may nagtanong sa atin na student, Doc, sabi ng gynae ata, HPV is the most common. But of course, that's a virus. No? So you need to quantify it. No? We need to, qualify. No? You have to put qualifiers. No? This is in the setting of a bacterial STD. Okay? And this is worldwide data. Okay, in the Philippines, of course, we don't have that data kasi hindi naman tayo nagtetest for chlamydia. Diba? Gonorrhea yung tinetest natin. Tapos we say, gonorrhea ang pinaka-common sa atin just because we don't test for chlamydia. Okay? Pero global data, chlamydia pa din more than gonorrhea. Okay, it can also cause neonatal pneumonia and LGV, lymphogranuloma venereum, specific for the subtype L1, L2, L3. Bartonella henselae, it can cause cat scratch disease. Yersinia enterocolytica, it can cause pseudoappendicitis or what you call mesenteric adenitis. So simply inflammation of the what you call this, lymph nodes. Yung lymph nodes sa natin, no? Along the mesenteries, no? Sa intra-abdominal lymph nodes. So it mimics na kala mo nagkaroon ka ng appendicitis. Si Klebsiella granulomatis naman, new name na yan. Baka familiar tayo dun sa old name, no? Calimacobacterium granulomatis. This is associated with the beefy red ulcers of donovanosis. Okay? So, minsan malilito din tayo dun sa characteristic ng ulcer. Recap. Hard chunker, hard ulcer, na parang cartilaginous inconsistency, you think of syphilis. Soft chunker, na painful, you think of H. Ducreyi, di ba? Beefy red ulcer, mukhang samgyup, no? So, donovanosis, itong nasa picture natin. Okay? So, you can also have those pseudobubos. Okay, so they are simply a granuloma, no? Hindi sila inflamed lymph nodes. Kasi ang totoong bubo ay lymph node. Okay? Kung peking bubo, granuloma lang yan. Nagpapanggap na bubo. Okay? Sige. So, pag-usapan natin ng konti yung mga viruses, no? So, just the key points. So, yung mga myco na part, usually konti lang naman yun, no? So let's focus on the things na ang kailangan natin i-emphasize. So sa viral morphology, you have helical, icosahedral, and complex as the structure. Pag narinig niyo yung term na complex, isa lang yung iisipin mo dyan na important medically, pox viridae. Okay? So wag ka na magsasagot ng complex kung hindi pox yun nasa tanong. Okay? Unless alien na virus yun na ngayon mo lang narinig. All DNA viruses are icosahedral except for pox virus because it is complex. So pag-usapan din natin yung segmented genome. So you have the BOR acronym, Bunia orthomyxoarena rheo. So very important dito is orthomyxoviridae causing influenza. So positive stranded RNA virus. So ang gusto ko lang tandaan natin, pag positive stranded, para siyang mRNA. So it can be directly translated. Pag negative-stranded, ito yung kailangan ng RNA-dependent polymerase. Okay, so meron tayo acronym na always bring polymerase or fail replication. So sino yon? Yung mga negative-stranded RNA viruses. Memorize na lang natin. Okay? So si DNA viruses, no, hindi sila pwedeng i-translate directly. So kailangan pa din na lang maging positive-stranded RNA that looks like your mRNA or rather functions like your mRNA, then translated to proteins and enzymes. Okay, so yun. So here, sino nga uli yung ignored? Yung positive. Okay? Kasi positive ka na, happy ka na sa life. The positive strand is simply ignored, while the negative strand, yun yung pagtutuunan natin ng pansin. Yung negative, it has to be fixed. Diba? So yun. So viral genetics, recombination, simply exchange of genes, reassortment, no, would only be true for those segmented genomes na viruses, like your Bohr, di ba? In particular, yung Orthomyxoviridae causing influenza. Complementation, may isang sira, may isang ayos, together, ayos na sila. Okay, so functional plus non-functional, it was a functional virus, no? Or a viral protein. Phenotypic mixing, wala talagang exchange of genetic information. Tumabi ka dun sa kaibigan mo na mahilig sa ganito. So parang nagmukha ka na rin mahilig sa ganyan, no? Labo no example ko, pero na-gets natin, 'di ba? 'Yun ang mahalaga, 'di ba? So parang you're assimilating the features. Okay, so DNA viruses, so we have those organisms, so memorizein natin yung DNA viruses, yung RNA, wag na nating memorizein, sayang sa memory space. Pag hindi siya DNA virus, di RNA, ganun na lang natin siya isipin. Pag hindi ko alam, di RNA, kasi mas konti yung DNA. Okay, so you have this figure over there in your handouts that lagi kong ina-emphasize nandito. Ang hirap tandaan kung sino yung mga circular, linear, hindi naman sobrang particular tayo dito. What you just need to know is sino yung DNA viruses na single-stranded, which is your parvovirus B19, causing erythema infectiosum with a slab cheek appearance. Okay? So, sino nga yung hindi double-stranded? Kasasabi ko lang. Pag hindi ito naalala, nako, so it's your parvovirus. Linear DNA, tandaan na lang ang exceptions. Okay? So ako not so particular ako dito, but if you have extra energy, tandaan na rin sila. All DNA viruses are ecosydal, nasabi na natin pox virus, and they replicate in the nucleus except pox because it's too big. Si HSV, no? Ito, no, pinapakita natin dito, medyo binago natin siya sa handouts ninyo, no? Because this is the classic description of HSV 1 and 2. Kasi baka for exam purposes, itanong pa rin, so sabihin pa rin natin, no? So si HSV1, saliva, HSV2 through sexual, yung primary means of transmission, okay? Again, they are not mutually exclusive. HSV1 can also be obtained via sexual contact, and HSV2 can also be obtained via kissing, ganun, saliva, and direct contact, no? So they're not mutually exclusive, pero ito yung mas characteristic, kumbaga, na feature niya. Okay? So lagi ko na lang tinatandaan dyan, 'di ba, saliva, 'di ba usually naman yung mga tao di kiss first before HSV2, yung ganon, 'di ba? Alam niyo na 'yon. Baka may MTRCB tayo, 'di ba? So, mahalaga pumasa tayo sa exam, 'di ba? So, 'yon. So HSV1, where is the site of latency? Trigeminal ganglia, 'di ba? Saliva, oral. So, nandun. Lumbosacral HSV2 along the genital area. But again, that's just the oversimplification of things. Okay? So, I'm sharing this kasi sa exam baka tanungin pa din. Okay? Pwede tayo tanungin, what would be a simple, cheap, what do you call this, bedside test that you can perform in order to give a presumptive diagnosis of herpes simplex virus? Answer is your chunk smear. Okay? So varicella, may multinucleated giant cell din. This time, ang site of latency is the dorsal root ganglia. Napag-usapan na natin yung centripetal and the centrifugal. This one would have a dewdrop on rose petal appearance. Rey syndrome, baka itanong sa pedia, this is associated with aspirin use, especially among the pediatric population. Okay? So dinagdag ko tong picture na to para, again, to re-emphasize what I said earlier. Si chickenpox, no? Majority of the rashes are seen where? Nasa gitna, 'di ba? So it has a centripetal distribution, okay? But how does it spread, no? It spreads from the gitna to the extremities, okay? But it doesn't mean to say na mas marami yung nasa peripheries, okay? So tama naman si Patho. So sometimes na mix up talaga to no? So, yun. Cross-checking this with multiple references, Harrison's would also describe it as a centripetal distribution and a centrifugal spread. Hindi lang niya ginamit yung terms na yun kasi pangit nga yung terms na to. Dapat alisin na siya, no? But for exam purposes again, no? So, kailangan pa rin natin silang tandaan. Zoster, alam na natin yan, no? So, this is a reactivation of your varicella. You can have the Ramsay-Hunt syndrome when there's involvement of the geniculate ganglion. CMV, you have the Als-I nucleus, and this causes an infectious mononucleosis type of infection. Okay? So, but the key difference here is that it is heterophile negative. Okay? Ano ba yung heterophile? Actually, hindi naman siya ganun ka-significant sa buhay natin. This is just a laboratory thing. Diba? When you say heterophile antibody, but simply the production of an antibody, no, not to the specific antigen itself. Diba? So para to related antigens lang siya. So yun. So it's really more of a laboratory thing. Pag heterophile positive, it's Epstein-Barr. Negative mononucleosis, cytomegalovirus. Okay? So si Epstein-Barr, nasabi na natin. So kung kanina may Als-I cells, no, Als-I inclusion. So Epstein-Barr, you look for the downy cells. Okay. So this is your kissing disease, and a complication can be splenic rupture. Okay, so iba-iba yung triad nito. That's why I'm not gonna emphasize this one. Kasi di ba yung sinasabi nila, triad of infectious mononucleosis, iba sa pedia, sa micro, sa Javets, wala namang mention. But suffice to know, if you have sore throat, lymphadenopathy, and splenomegaly, that points towards Epstein-Barr virus. Okay. Iba-iba ang malignancy associated with them. That's why ang important dito is titignan natin yung geographical distribution ng tao na pinag-uusapan. Kung Chinese ka na nagka-EBV ka, the associated cancer is nasopharyngeal carcinoma. African ako, nagkaroon ako ng Epstein-Barr, you think of more of Burkitt lymphoma. Okay? But alam mo sa Philippines, meron ding mga Burkitt lymphoma. Pero ayoko kayong lituhin, ha? Baka kasi pag nagpa-practice na kayo, sabihin nyo, sinungaling yung lecturer namin sa micro. Sabi yung Burkitt lymphoma, usually EBV African people lang. Bakit meron sa Pilipinas? Okay? It's just that we don't have data. Kaya wala tayo sa libro. Diba? Kasi we don't have a lot of studies, we really don't have a lot of data to support yung mga common sa atin. Pero we really see it eh. Sa PGH pa lang, napakaraming may ganyan, no? A lot of them would also have concomitant EBV. Okay, so sa mga may HIV patients, CNS lymphoma and hairy leukoplakia. HHV6, pwede tanongin sa IM. Which infection is associated with Rosola? Sagot, HHV6. No? Which infection can be associated with pityriasis rosea? Katunog ng Rosola, rosea. So answer is still HHV6. Okay? So sa bata, exanthem subitum, sa matanda, pityriasis rosea. Okay? But again, it's still an association. Hindi pa clear yung mga references natin dito. Okay? So Kaposi sarcoma associated with human herpes virus 8. Again, this is also related to different geographical distribution as well. Okay? And population. So pox, nasabi na natin, replicates in the cytoplasm and largest DNA virus. Hepatitis B. Okay, so pag-usapan natin ng konti kasi pwede rin itanong sa IM yung titers natin. Okay, so this is the only DNA na virus that produces DNA by reverse transcription. And remember na in hepatitis B, it does not directly cause injury to the cell. Okay, it's your own body, no, that's causing injury. Okay, and that is the reason why this one is very important. Okay, recap natin. So acute infections, hinahanapin basta kapag sinabi ko nung lecture, di ba? Basta kapag the infection is present, then HBsAg should be there. If it's acute or chronic, regardless if it's high infectivity, low infectivity, the HBsAg should be there. Okay? So guys, walang magda-diagnose ng chronic Hep B na HBsAg negative. Please lang. Okay? So that's a common mistake among the residents. Ngayon, bakunado ako. Meron akong anti-HBs positive, but you also have anti-HBC. So that cannot be. You will only have anti-HBC if you were infected before. Okay? So nakita niyo dito sa table natin, di ba? Anti-HBC is a marker na dati ka or presently ka nagkaroon ng infection. That's why for patients na binakunahan lang, the only antibody that should be positive is anti-HBs. Nothing else. Okay? Klaro yun na nothing else. Only this one. So also important to mention that we no longer use the terms high infectivity and low infectivity in actual practice. No, we now say chronic hepatitis B HBeAg positive, chronic hepatitis B HBeAg negative. That's now the new nomenclature that we use because it's not necessarily true na porket yung HBeAg positive, highly infectious, ganun. That's just, again, a generalization that's still true for micro, no? Kasi of course, ano tayo, general subject tayo, di ba? Basic science subject tayo. So sa JAWETS, yun pa din naman. But in actual practice, just so we are clear, we use the terms HBeAg negative and positive already. Okay? So yun. So you can, you can look at this, what do you call this? This figure, no? To determine yung duration kung kailan siya magpapakita. Okay, so some key points again when it comes to the titers. The only positive during the window period is the anti-HBC IgM. Window period meaning to say, andito ba? Wala. Ito, yung sinasabi ko, the window period, no? So from the time that you get infected, no, bago maglabasan yung mga antibodies natin, it's really just the anti-HBC. Okay? Medyo confusing yung figure natin dito, no? Kasi merong anti-HBe. Okay? Labo, di ba? Pero ignore natin yan, no? Kasi usually it's still undetectable at this point. Okay? So the only positive antibody during the window period is anti-HBC IgM. Okay, so palitan nga natin yung figure, no? Nakakalito. The only positive among vaccinated patients, na mention ko pa ulit-ulit, anti-HBs. Chronic infection is characterized by the persistence of HBsAg for at least 6 months. So kapag more than 6 months na, you can say it's already chronic. Okay? And what rheumatologic condition or vasculitic condition is associated with Hep B infection? The answer here is polyarteritis nodosa, Hep B. Okay, hepatitis B equals polyarteritis nodosa. Hepatitis C, no, dagdag ko lang dito na naisip ko lang, equals yung mga cryoglobulinemic vasculitis. Okay? So treatment, you can give interferon, lamivudine, okay? But again, wala na nagbibigay ng ganyan. Sa mga micro-textbooks lang yan. In IM, pag tinanong kayo, anong treatment ang ibibigay nyo? Tenofovir. Okay? So mas tenofovir na yung binibigay natin nowadays. We shy away from interferon and lamivudine already, but they are still viable treatment options. Okay? Hindi ko sinasabing mali ang libro. What we're saying is, in actual clinical practice, what we're using is more of tenofovir. Okay? Tenofovir disoproxil fumarate. Okay, so you have your figure over here. Basahin na lang natin. So you can use this more as a guide. So all viruses are haploid except for retrovirus. They replicate in cytoplasm except for influenza and retroviruses. And then all of them are single-stranded except for reoviridae. Okay, so isa sa mga virus na gusto ko i-emphasize is rabies kasi may student na nagtanong, no? So how does rabies go to the CNS? It's via retrograde axonal transport. Okay, so we want to emphasize it's retrograde because it can be anterograde, diba, for other organisms. So this one is retrograde axonal transport. And there are two different main types, no, of rabies. You have the encephalitic and the paralytic, but majority of them would be the encephalitic form. Okay, may nagtanong na student na, Doc, ano yung tanong? Why do the ano yan? Kaya ko to. Kakabasa ko lang kanina. Bakit daw nagkakaroon lang ng rabies yung animals after they bite somebody? Okay? Bakit siya namamatay after that? Why not before? So why did they acquire the rabies after biting you? Okay, so the answer is they did not acquire the rabies after biting you. They already acquired it prior. It just so happens that by the time that they are already very infectious, no, in encephalitic form, no, they have features of aggression, diba? Yun, so agitation. So the same is true for animals, no, not just for human beings. No, nagiging aggressive din sila, so they bite, diba? So ibig sabihin infected na sila, kaya sila nangagat. That's why they die afterwards. Okay, so hindi sila nagkaroon ng rabies after biting or through the biting process. Okay, rarely you can have the paralytic form that is characterized more of flaccid paralysis. So parang mas tetanus yung presentation, di ba? Okay, death is virtually certain for everyone, no? So ito yung may nagtanong kasi na student, so dinagdag ko to. Sabi ng student, Doc, what if may pusa na nag-lick ng plate tapos kinainan mo yung plate? So something like that. Would that be a category 1, 2, or 3? What do we do? Do we give vaccine or do we give the ring? So tignan natin yung recommendation. So this is based on the PISMID. Okay, so pag-usapang rabies, no? Rabies para Pinoy na Pinoy. Pag-usapang rabies, diba? We follow the local recommendations. Okay? Because in other countries, they don't have a lot of rabies, diba? So even in practice, in San Lazaro, yung center natin for infectious diseases, we really follow the PISMID recommendation. So ito yung gagamitin natin. Okay? You can take a picture kung gusto nyo ano, or you can actually just search it online. PISMID na rabies, okay? So feeding or touching an animal, sharing utensils, ito yun. So I think it falls under this one. Sharing of utensils or sharing of eating or drinking utensils. Although dito sabi kasi patient, diba? So I think the same is true siguro kung laway ng animal, right? So in that case, you don't really need to give vaccine or rig. You just need to observe, no? Wash the exposed skin immediately with soap and water, okay? But this is only true kapag yung patient is only suspected of having rabies. May signs and symptoms but not really proven. Okay? Bakit? So later, I will emphasize why. Casual contact to a patient, no, wala ka namang significant exposure, you're just handling the patient, you don't really need to have any vaccination. Okay? But of course, you can consider pre-exposure prophylaxis if you're really at a high risk. So category 2, nibbling of uncovered skin, minor scratches, abrasions, and category 2 na nasa head and neck, they are automatic na malilipat sa category 3. Kasi kapag category 2, start vaccine immediately tayo. Okay? And rig is not indicated. Category 3, sabi natin, category 2 na nasa head and neck kasi malapit sa brain, di ba? It goes retrograde axonal transport. So automatic, nagiging category 3 sila. So kapag category 3, dumugo, no? Transdermal no? So malalim, may dugo, no? So licks on broken skin or mucous membranes or exposure or contamination of mucous membranes. Okay? So ito yung sinasabi ko na yung caveat natin, balik ako ng konti, ha? Sabi dito kanina, exposure to patients with signs and symptoms by sharing utensils. So category 1 yan. Pero kapag sure na may rabies, exposure via means of mucous membrane, di ba? Pag nag-share ka ng utensils na may laway, it's mucous membrane. So parang it also follows, right? Kung sure na exposed ka sa rabies patients, then I think it would be safer to answer category 3 in this particular situation. Okay? So gets yun na? So pag ganun, start vaccine and rig immediately. Okay? Other situations under category 3, exposure to bats, ingestion of raw infected meat and handling infected carcass. So vaccine and rig immediately. HIV, patapos na tayo. We're down to our last few slides. So HIV, ito pa din naman, no? Kasi baka magtaka lang kayo, no? In actual practice, we don't often do Western blot, di ba? Mas medyo academic. But the definitive diagnosis is still Western blot. Okay, so that's the confirmatory test. And as a definitive diagnosis, ECP natin, of course, it has to be specific more than sensitive. Because screening tests have to be sensitive. Di ba? Meron tayo acronym na SPIN and SNOUT. Di ba? Ano nga ba? Yun. So naalala nyo yun sa PrevMed, di ba? For rule in, rule out test. Okay? So pag screening, that's our rule out test. Okay? So they're more sensitive than they are specific. So ito, mention din natin, antiretrovirals, they are usually, what do you call this? They would consist of 3 drug regimens. But personally, I think you don't need to memorize all of those drug combinations. Di naman tayo tatanungin ng ganun ka-specific. Okay? So, just tandaan lang natin, nasa textbooks, paano ba yung combination? Usually 2 NRTIs and 1 protease inhibitors. Okay? Kasi sa actual baka experience niyo, iba rin yung nakikita ninyo na binibigay, di ba? So, for exam purposes, ito yung tatandaan. Ito, tinanggal natin. Okay? So, bakit ko pinapakita kung tinanggal nga natin? Kasi baka nakikita nyo siya in other references. Tapos, magtataka tayo, bakit hindi dinuro sa IM? Because this one has no legitimate reference. That's why we removed it. We opted to remove it for uniformity for everyone's purposes. So, wag nyo na tignan, takpan nyo yung mata nyo. Ina-explain ko lang, no, na wala talaga tayong solid basis to say na TB start ganito, HS we start at ganyan, okay? But what we have a solid basis for is CD4 less than 200, we start prophylaxis for pneumocystis cerevisiae pneumonia. Correct? Naalala yun? CD4 less than 50, you start prophylaxis for MAC, Mycobacterium avium intracellulare complex. Okay? You give azithromycin for MAC, you give cotrimoxazole for pneumocystis cerevisiae. Okay? Yun yung meron tayo solid na reference for that. Okay? Sige, so iris, no? So, ang point lang natin dito is TB treatment should be initiated first, no? Kapag merong iris, and then followed by ART as soon as possible within the first 8 weeks of treatment. Okay? So that's already my last slide. So hopefully, na-refresh tayo. Okay? So hopefully as we were going through the different topics that we already talked about before, so mas nagkaroon ng clarity na. Alright? So thank you so much. And I turn you over back to our...
All right, thank you so much, Doc John Borbe. I think I have one question sent to you, Doc, sa sa private message. Did you see it, Doc?
Wala. Teka lang, titignan ko. Baka natampikan kasi maraming nakalagay dito na joined as a guest.
So, the question is, good evening po, Doc, regarding po sa page.
Ito, nabasa ko na. Okay, nakita ko na.
All right.
Muted ba ako? Ay, hindi ako muted. Okay, nabasa ko na. Sabi, regarding page 37 sa micro handout. So, CMV is HHV3 po agad. OMG, HHV3 ba sa handout? Let's correct that. No, mali yun, no? So, HHV, ano ba ang CMV? 5. Okay? Because 1 and 2, herpes simplex. 3 is varicella zoster. 4 is Epstein-Barr. 5 is CMV. 6 is Rosola. 7 is yung, what do you call this? Kaposi-like, or what do you call this? Rosola-like din. So, yung 7, ano yan? Question mark na malaki pa yan, depending on your reference. Si HHV8, yung sure na Rosola na ano, sure na Rosola tuloy, nalito lalo sila, sure na Kaposi sarcoma yon. Okay, so yung 7 yung medyo malaking question mark. Okay, so kindly correct that, ha? So si 3 ay varicella zoster, 5 is CMV.
Okay, so once again, thank you so much, Doc John Borbe, for that very informative and siksik no sa content na summary lecture. Doc, can I share my screen? I think you're still sharing your screen. All right, there you go. Okay, so now let us proceed to our next part of this session. Let me just share my screen. Let's go to our Quizmaster. So please prepare, guys, your answer sheets, your bubble sheets. Okay, hold on. Ayan. Can you see my slide? Is it hindi naman siya naka-presenter view? Hindi naman. Hindi na po. Okay. Thank you. Sige, so let's start. All right, next question. Question number 3. Question number 4. Question number 5. Question number 6. Question number 7. Question number 8. Question number 9. And for our last question, all right, so that's our last question. Doctors, please keep your answers, and then later when I launch the poll, just cast your vote sa poll natin. Okay, so now help me welcome our quizmaster for this evening, Dr. Marcus Cesar Damasco. Doc, good evening. Teka, let me stop my screen. Okay. Sige, Doc, take it away.
So, good evening, everyone. I'm Dr. Damasco, recent board passer. Welcome to our Quizmaster session for this evening in Microbiology and Parasitology. So, let's start with the answers and explanation. So, first item, no? A 50-year-old male with poorly controlled TM presents to the ER with symptoms of PKA. Okay. He has facial swelling and bloody nasal discharge. A necrotic eschar is also noted on the nasal cavity. Biopsy reveals non-septate, broad-based hyphae that branch at right angles. So what's the most likely positive agent? Wait ko lang matapos yung poll.
Sige, Doc, they only have siguro mga 10 seconds lang. Kasi nag-answer naman na sila kanina. They just have to
Sige.
post the votes na lang. And then read na lang, Doc, the results. Kasi for the doctors online sa portal, they won't be able to see kasi the results. So you can read the results na lang. Thank you.
All right. So, yun, majority of you answered A, aspergillus. Pero yung answer dito is Rhizopus oryzae. So ano ba muna yung diagnosis dito? Patient na may DM, will present as DKA, and meron siyang facial swelling, tas meron siyang necrotic eschar. Doon pa lang, parang presentation ito ng mucormycosis. Pag sa question may nakita kayong DM with necrotic eschar, isipin mo parang mucormycosis na agad siya. Additional na info, biopsy reveals non-septate broad-based hyphae that branch at right angles. Isa pang buzzword ito for mucormycosis, yung branching at right angles. So Rhizopus oryzae, siya yung most common cause ng mucormycosis. Other causes ng mucormycosis, mucor species, meron naman, pero Rhizopus yung most common cause niya. So hindi siya aspergillus, fumigat. So, for aspergillosis, usually respiratory symptoms. For chronic aspergillosis, it can cause aspergillomas. Invasive aspergillosis can invade the blood vessels and cause infarction, thrombosis. So, hindi siya necrotic eschar on the paranasal sinuses, facial swelling, and bloody nasal discharge. Also, sa histopathology nito, ng aspergillus, septated yung hyphae niya. Tsaka as opposed sa mucormycosis, acute angle yung branching niya, hindi right angle branching. For coccidioides immitis naman, in the body, it presents as spherules containing endospores. Sa blastomycosis, round yeast with broad-based body. So, blastomycosis, ang palatandaan niyan, blastomycosis BBB, broad-based body. Yung both C and D, coccidioides and blastomycosis, they present as respiratory, more on respiratory. Tsaka yung coccidioides, siya yung nagkakos ng valley fever. So, ito yung this is an example ng case ng mucormycosis. Makikita niyo yung necrotic black eschar. Yung eschar na to, it can spread hanggang sa mouth and sa orbits. And yung distinctive feature nga ng mucormycosis is yung right angle branching. Pag may nakita kang right angle branching hyphae, mucormycosis na yun. Tapos, at risk for mucormycosis yung patients with DM, leukemia, lymphoma, patients that have had corticosteroid treatment, and patients that has mahinang immune system. So, ito yung itsura ng hyphae ng aspergillus sa kaliwa. Mapapansin nyo, may septations talaga siya. Tsaka mas narrow, parang pavi, sabi nga ni Doc sa lecture kanina. Parang siyang pavi, as opposed sa mucormycosis. Pa-L, right angle fracture. Fungus that can cause a fungus ball in lung cavity. Nabanggit ko to. This is aspergillus. So, yung aspergillus, nagkakos siya ng aspergilloma in patients with previous TB, bronchiectasis, kung saan yung meron ng pre-existing cavitary lesion. What carcinogen is produced by aspergillus? This is aflatoxins. So, aflatoxins produced by aspergillus increases the risk for hepatocellular carcinoma. What's the form of Candida albicans in cooler temperatures? It is the yeast form. So exception siya sa ibang dimorphic fungi, no? Siya in room temp or cooler temperatures, yung Candida yeast siya, as opposed sa pag in-incubate mo siya sa higher temperature, sa 37 degrees Celsius, mag-elongate yung yeast at magkakaroon ng germ tube appearance. So next question. Gram staining of a blood sample sent to the laboratory showed gram-positive toxide. Further testing showed that this organism is catalyst positive, coagulase negative, and novobiocin sensitive. So this organism is most likely. So na-discuss din kanina sa lecture. No? Okay, very good. Majority answered naman, staph epidermidis. No? Kapag ganito, gram-positive toxide, catalase positive, alisin mo na yung strep kasi catalase negative siya. Coagulase negative, alisin mo na si S aureus kasi coagulase positive siya. So, dalawa lang yung natira sa'yo, B at C. Sino ba yung novobiocin sensitive? Epidermidis. So, yung mnemonic dito para hindi malilimutan. No stress. Novobiocin, mas malapit yung S sa R, so saprophyticus resistant, and then yung E sa S, epidermidis is sensitive. So, na-lecture din to kanina pero I'll go over it na lang ulit ng mabilis. So, for gram-positive toxide, differentiate strep from staph by the catalase test. If nagkaroon ng bubbles, meaning nag-positive staph, and you differentiate more pathogenic strains ng staph from less pathogenic ones by using coagulase test. Kapag nag-plot, yun yung SRUs, pag coagulase negative, yun na yung grupo ng coagulase negative staphylococcus. So kapag sensitive, it's epidermidis, it's resistant sa prophyticus. Sa strep, no? As nabanggit naman kanina, based sa hemolysis. If alpha hemolytic, either viridans lang yan or S. pneumoniae. If optochin sensitive and bile soluble, tsaka encapsulated S. pneumoniae, if negative siya doon, it's viridans strep. Viridans group composed of S. mutans, S. mitis, S. sanguinis. So, kapag beta hemolytic, you do bacitracin sensitivity. If sensitive siya sa bacitracin, it's group A or yung strep pyogenes. If it's resistant, it's group B as Agalactiae. Palatandaan ko sa group B for bata. Kasi siya yung cause ng sa neonates, no? Yung neonatal meningitis, etc. So for gamma hemolytic, kapag no hemolysis siya, you differentiate by growth sa 6.5% sodium chloride. Kapag may growth, group D enterococcus. Kapag wala, it's S. bovis. So yung isang important sa S. bovis mo, associated siya with colorectal cancer. Dito lang sa branching filaments, ang important sa nocardia, weakly acid fast siya. Kapag dito naman sa gram-positive bacilli, nakikita na sa anaerobes, si Clostridium, Macrostridium, and si Propionibacterium, yan yung nakikita sa acne. Yung Listeriosis, Bacillus, and Corynebacterium, sila yung gram-positive rod na aerobic. Sa prophyticus is resistant sa novobiocin. So what's the toxin of staph aureus that causes rapid onset food poisoning? This is yung enterotoxin. So next question. What is the appropriate culture medium for Legionella pneumonia? Nabanggit din to kanina. Okay, very good. Majority answered C. Buffered charcoal yeast extract. Kaya ko tinanong to kasi lumabas siya sa amin. So, buffered charcoal yeast extract. No. Yung XLD for Salmonella and Shigella, yung CIN, this is for Yersinia. Yung Yersinia, meron siyang bullseye appearance sa CIN. And yung Bordet Gengu agar for Bordetella. Other agar pa sa Bordetella, yung Regan. Another thing to note pala sa buffered charcoal yeast, Dinadagdagan din to ng cysteine. Kasi yung cysteine, kailangan siya ng Legionella for optimal growth. Yan. So, familiarize yourself na lang kasi minsan ginagawang kasama siya sa questions then as clue or mismong siya yung tanong. So, pag perfringens, egg yolk agar, kasi nga merong lecithinase yung perfringens. For diphtheria, cysteine tellurite, and Loefflers. So, pag may growth sa bile aspilin, yung group D strep, chocolate agar and Martin, or Neisseria. Tapos, yung Haemophilus influenzae, siya yung maarte, kailangan niya ng factors X and B for sa chocolate agar. S. aureus, mannitol salt agar, and yung E. coli, nag-create ng green metallic sheen sa EMB agar. So, what's the culture media for Helicobacter pylori? The Stewart's medium. Ito. EMJH or the Fletcher's medium is used to culture what? Used to culture Leptospira. Lowenstein-Jensen medium is used to culture Mycobacterium tuberculosis. Okay, next question. 4-year-old male developed fever, coryza, and sore throat, which eventually resolved. 2 weeks after his previously stated symptoms, a rash with a slap cheek appearance appeared. So this disease is caused by an agent which has the following characteristics. Nabanggit din to kanina. So very straightforward question para lang mas maalala niyo. Okay. Very good. Majority answer. Tama, which is B. So, ano ba muna yung diagnosis? 4-year-old nagkaroon ng prodromal symptoms of fever, coryza, and sore throat. Then, nag-resolve 2 weeks after nagkaroon ng slap cheek appearance. So, this is erythema infectiosum or tick disease caused by parvovirus B19. Parvovirus B19 is part of the Parvoviridae family. It is a naked, single-stranded DNA genome na may icosahedral symmetry. So, what antigen does parvovirus B19 target? This is the P antigen found on erythroid progenitor. Kaya nagtukos ang parvovirus B19 ng aplastic crisis, more specifically, nagtukos siya nun sa patients with sickle cell disease and thalassemia, etc. Kasi in those patients, compromised na nga yung production nila ng red cells. Paano pa pag na-infect sila ng parvovirus B19? Lalong nakahalt yung production ng RBCs. Kaya nagkakaroon ng aplastic crisis. What disease is caused by parvovirus B19 in fetuses? So this is hydrops fetalis. So this is in response sa sobrang babang hemoglobin, RBCs, na compensate yung fetus, nag-overproduce ng fluids and RBCs, which can go to various fetal compartments. No? It can go to the subcutaneous tissues, body cavities, even the skin, kaya nagkakaroon ng hydrops fetalis. So next question, nabanggit dito. Which serovars of Chlamydia trachomatis are responsible for lymphogranuloma venereum? Okay. Okay, very good lahat. Nag-answer, almost everyone sinagot na correct answer, which is C. So, lymphogranuloma, may L. L1, L2, L3. Yung serovars A, B, and C sa trachoma. B to K sa genital tract infection. So, as stated kanina, Chlamydia trachomatis has multiple serovariants. For trachoma, yung image sa right side, this is an example of a trachomatous inflammation. So, It can lead to chronic keratoconjunctivitis that can cause scarring and blindness. Trachoma is one of the leading causes of preventable blindness worldwide. For types dito kayo naman, nabanggit nga rin kanina na most common cause siya ng bacterial STDs and associated siya with birth complications like neonatal conjunctivitis and pneumonia. Associated siya with Reiter syndrome or reactive arthritis, so pneumonic na Kensi, Kenpi, Kenclimatry, yung magkakaroon ng conjunctivitis, urethritis, and arthritis. And yung sa question, which is types L1 to L3, lymphogranuloma venereum, wherein nagkakaroon ng papillar or vesicular lesions that can lead to suppurative inguinal lymphadenitis or bubo. Yung pseudobubo sa donovanosis. So, what are cytoplasmic inclusion bodies located near the nuclei of conjunctival epithelial cells in trachoma? So these are Halberstadt-Prowazek inclusion. So Halberstadt-Prowazek inclusion contains aggregates of Chlamydia trachomatis na nakikita siya sa conjunctival epithelial cells. So it's one of the histological hallmarks ng trachoma. So what stage of C. trachomatis enters the cell? So nabanggit din kanina, yung elementary body. Kung nagre-replicate naman intracellularly, this is the reticulate body. So ito ulit yung mnemonic. Sa elementary body, gawin mo na lang ilahat. Infectious enters the cell via endocytosis. Sa reticulate body, it replicates in the cell. So next question. A 26-year-old male complains of fever, abdominal pain, and bloody stools. Gram-stained revealed gram-negative shaped rods, and the oxidase test is positive. The organism showed optimal growth and Schiros agar at 42 degrees. So, which organism? So, andito na yung mga parang buzzword ng organism na to. Schiros agar, 42 degrees Celsius. So, very good. Majority answered B. No, Campylobacter. This is Campylobacter jejuni. Comma-shaped rods or S-shape or gull-wing shape. Tapos bloody stools, Campylobacter jejuni. So hindi siya si Vibrio cholerae because hindi siya typically nagkakos ng bloody diarrhea. More on voluminous watery diarrhea or rice water stools. Also, it grows best yun nga nabanggit kanina, yung TCBS or alkalinuridia. For Shigella sunni, nagkakos din siya ng bloody stools or dysentery, pero hindi siya coma-shaped at iba rin yung other niya. Shigella sunni is also called the Duval's bacillus and the most common cause of bacillary dysentery. Yung Shigella dysenteriae naman, siya yung cause ng most severe form ng bacillary dysentery. At yung Shigella dysenteriae, siya yung most common cause ng epidemic dysentery. For Salmonella typhi, this is a cause of enteric fever. Yung Salmonella typhi enteric fever, it can cause bleeding after later on sa disease, yung kapag na-rupture na yung sa terminal. At may notable na buzzword dito yung rose spots or yung salmon-colored patches sa abdomen and sa trunk. Yung rose spots. Kaya ko lang nilagay yung oxidase negative para ma-differentiate sila sa ibang choices. And yung H2S, important to remember na yung Salmonella, siya yung H2S producer, tsaka yung Shigella, siya yung non-producer sa TSI. So, ito, sa comma-shaped rods, yung mapapansin nyo, lahat naman sila oxidase positive. Sa bacilli, you can differentiate them by their lactose fermentation, as nabanggit kanina. If rapid lactose fermenters, yung mnemonic na Eke, E. coli, Klebsiella, and Enterobacter. If slow, that's Citrobacter, Serratia. If non-lactose fermenter naman and oxidase positive, it's Pseudomonas na. And if non-lactose fermenter And oxidase negative you you differentiate the others by HUS production on PSI agar. Yung nabanggit niya kanina, yung salmonella yung producer, HUS. And yung Yersinia and Proteus, may iba pa yung distinct na morphology no, nabanggit ko kanina sa Yersinia. Meron siyang bullseye appearance on CIN, yung Proteus, yung swarming motif. At yung tandaan nyo rin yung maltose utilization ng meningitis, as nabanggit nga, maltose, nag-utilize siya ng maltose and glucose. Yung gonorrhea, glucose lang, kasi G lang meron siya. Yung Neisseria, may meningitis, may M, tsaka may G. So what immune-mediated pathology can C. jejuni infections cause? So this is GVS. So important to note din no na yung C. jejuni it is also associated with Reiter syndrome or reactive arthritis. So what antigen is seen in Vibrio cholerae flagella? So it is the H antigen. So next question. 33-year-old female came into the ER after sustaining leg wounds and an open fracture on her left leg in a motorcycle accident. A few days later, her leg became swollen resulting in bleeding from her leg. Crepitus can be felt on her leg. Gram staining showed gram-positive blood. Growth of the organism on the blood agar showed double zone of hemolysis. So, what's the most likely organism? Okay. So, very good. Majority answered the correct question, which is Clostridium perfringens. So, nagkaroon siya ng gas gangrene. Yung gas gangrene, kaka siya sa clinical findings ng Crepitus. And yung important din na first na Clostridium perfringens, nagkaka siya ng double zone of hemolysis sa blood agar. Clostridium tetani, or yung nabanggit niya kanina na muscle spasm, stiffness, and dysautonomy. Staph aureus can cause cellulitis and soft tissue infections, but it's not typically known to cause gas gangrene. For Bacillus anthracis, for cutaneous anthrax, hindi rin siya nagkakos ng gas gangrene, more on malignant pustules, ulcerative lesions, and necrotic eschars. So, ito yung double zone ng hemolysis ng Clostridium perfringens. May inner beta hemolysis caused by theta toxin and yung outer alpha hemolysis caused by the alpha toxin. So, Clostridium perfringens is anaerobic and spore-forming. So, anaerobic infection siya, so it fosters mixed infection. May growth din siya sa egg yolk at nabanggit nga meron siyang lecithinase. And makikita siya sa soil, kaya at risk yung mga na-aksidente sa daan, lalo na sa lupa, kasi nakikita sa soil yung perfringens. So also known to cause bacterial gastroenteritis. Tapos yung alpha toxin, siya yung lecithinase that cleaves cell membranes and the gas produced by anaerobic metabolism. Food poisoning, enterotoxin produced during sporulation ng daga causes yung hypersecretion. So what's the classic description of the morphology of C. tetani? Nabanggit kanina, yung tennis racket appearance due to its terminal spore. So which neurotransmitters are inhibited by tetanus toxin toxin? So this is GABA and glycine. So inhibitory neurotransmitters. So you inhibit the inhibitors, nakakaroon ng activators nakakaroon ng activation leading to spastic paralysis. So next question. A 35-year-old male gardener presents with multiple subcutaneous nodules over his right arm. Draining lymphatics became thickened and cord-like. Microscopic examination of the lesion revealed cigar-shaped yeast cells and asteroid bodies. What is the most likely diagnosis? Okay. majority answered yung sporotrichosis. So, multiple subcutaneous nodules, tapos lymphatics na nag-thicken, buzzword na agad doon ang sporotrichosis. At cigar ship, yeast cells and asteroid bodies, clincher na siya na sporotrichosis. Yeah. So for subcutaneous mycosis, important things to note, kasi usually isa o dalawa lang tatanungin dyan. For sporotrichosis, cigar shaped yeast, and asteroid bodies. For chromoblastomycosis, cauliflower-like lesions. No? Characterized siya by what we call it cauliflower-like lesion. Mycetoma, if you remember sa lecture kanina, mycetoma can be caused by actinomycetes and fungi, yung mycetoma. So, characterized siya by supergranules from interconnecting draining sinuses. Yung phaeopomycosis naman, ito yung merong melanin. Kaya darkly pigmented septic hydrae siya. So, sporotrichosis is also known as Rose Gardner's disease. Next question. A 6-year-old female presents with fever, sore throat, and small red vesicles over the back of the throat. The diagnosis of her pangina was made. So, what's the most likely etiology? Okay, so majority answer C, pero meron pa rin mga sumagot ng ABD. So, pag Coxsackie A, siya yung nagkakos ng hair pangina and hand foot. As opposed sa Coxsackie B, nagkakos siya ng myocarditis, pericarditis, pleuropnea, Epstein-Barr, yung infectious mononucleosis, herpes simplex, herpes labialis, or yung cold sores, and gingival stomatitis. So what does extreme pain in the lower chest caused by Coxsackie B? So this is called yung Bornholm's disease or devil's grip. So the devil's grip can mimic MI. Pero yung devil's grip or Bornholm's disease caused siya by inflammation ng intercostal muscles. The most common cause of aseptic meningitis is enteroviruses. So, Coxsackie virus along with poliovirus and echovirus, it can cause an aseptic meningitis. So, last question. Chrysops species is the vector involved in which of the following? Okay. Majority answered correct, which is Lowiasis. So, yung mga tanong na ganito, no, lumalabas talaga siya, lalo na pag yung micro medyo sa dulo siya. So, minsan na may mental block, nakakalimutan yung kung ano ba yung mga vectors. So, familiarize yourself na lang and pasadaan nyo siya 1 or 2 days before nung exam. So, yung other name ng Chrysops, siya yung deer, mango, or horsefly. Yung sa visceral leishmaniasis naman, sandfly yung vector niya. For river blindness, blackfly and simulium or simulium. For African sleeping sickness is the chechefly or lucina. So other notable dito yung sa Sundatel po sa Filipina or the freshwater crab. This is sa Paragonimus westermani naman siya. While yung kapag snail or Oncomelanotensis quadrasi sa Schistosoma japonica. So what nematode causes calabar swelling? So, lowa-lowa. What is the vector for relapsing fever from Borrelia rickettsial? So, ito, lumabas. So, this is the human body blouse. Okay? That's it. So, trust yourself. You've survived a lot. And you'll survive whatever is coming. Di si Master Ugay nagsabi, nilagay ko na picture niya. So, thank you and good luck.
Okay, so I guess that sums our session for tonight. Thank you so much, Doc Marcus, for the Quizmaster session for this evening. Okay, I guess we don't have any more questions. Is Doc Broly still with us? Okay, so thank you so much, everyone. So thank you so much, doctors, for joining our Quizmaster and summary lecture for tonight. See you tomorrow morning for our introduction to the next subject. Thank you so much, guys, and God bless. Happy Aral. Good night. Bye-bye.
Thank you po, Doc.
Thank you.
Thank you, Doc.
Thank you, Doc.
Thank you so much,
Thank
Doctor.
you.